spontaneous case of the patient, that is 17 out of 18, and headache result in 89%. So this is post-stenting. So transclinical pressure gradient increase and post-stenting. The 11 patient with mean transclinical patient was 18, result with 18.6 mmHg, and papilledema over a period of 6 months, it has resulted in 94%, and the patient that is 17 out of 18. Case of rhinorrhea post-stenting, both the patient, so transclinical pressure gradient increase and post-stenting within 6 months. The mean transclinical patient was 18, and 19, 18. One of the rare complications or an hardware failure that we had during this case of rhinorrhea post-stenting, both the patient, this was case we were resolved from the rhinorrhea, common femoral axis. So this is during our initial, this is one of the rare complication or an hardware failure that we had because of a sheathing issue with one of our, this was case we were doing from guide sheath. Common stent was partially deployed, so this is during our initial fixed to the guide sheath, and we were not able to completely deploy because of, and there was a sheathing issue with one of our aux guide sheath. The stent was partially deployed and got partially deployed fixed to the guide sheath, and we were not able to completely deploy the stent catheter, and there was also stent migration. So this is partially deployed stent with the stretched guide catheter. So gradually pull the stent along with the guide sheath, the whole system, into the common iliac vein, and we deployed the stent completely in the common iliac vein, and we completely along with the guide sheath, the whole system into the common iliac vein. So post this complication, we deployed the changed our protocol, and now if we completed stenting, we do it directly from ISVIR'. So post this complication, we changed our protocol, and now if they are doing stenting, we do it directly from ISVIR' rather than doing from common neuro guide sheath catheter.
Time's up.
So this is the stretch and broken cerebral transvenous stenting is promising in the treatment of medically refractory IIH for symptomatic relief and disease control. Transvenous stenting is promising in the treatment of medically refractory IIH, and our study showed resolution of clinical signs and symptoms like headache and papilledema, and our study showed resolution of clinical signs and symptoms like headache and papilledema, and even our case of larger randomized studies are necessary as our larger randomized studies are necessary as our study population only included 80 patients.
Thank you. Nice presentation, nice cases. Thank you. Nice presentation, nice cases. Questions. Couple of questions. Suppose a young female obese. Suppose a young female obese came with headache and MRI you have done. MRI you have done. Found all the features. How you are going to treat?
So if the patient is already usually if it is IH, MR and clinical things, we will put the patient on accessory for 3 to 6 months. Post that it is still refractory, we take them for manometry. So only if the manometry is showing more than 8, we carry on with this tent. Because in the study group of we had like 26 there are other 8 patient all signs like all the signs like features in MR and clinically. The pressure gradient was all of them had 2 or 3. So not well. These are not the ideal candidates. For stenting.
Should be refractory. What is the cause of stenosis? What is the cause of stenosis?
Most of the cases we couldn't identify the venous cause for the venous
giant arachnoid thrombus.
One of the case had only one patient had granulation, but it was significant to cause such a pressure. Most of the cases we couldn't make out any cause for the actual cause for the.
There is another hypothesis which is not intrinsic. It's not intrinsic, maybe because of extrinsic. So how you differentiate? If it is extrinsic, your stenting is not going to work. How you are going to differentiate?
So if it is an extrinsic, as in MR, so if there is any compression secondary to that, usually we will not take that case. It's not a case at all to take for manometry. Only if it is an intrinsic, if it is don't have any extrinsic compression, these are the cases we are taking for pressure management.
What is the dedicated stent for?
Using zero flex.
Do you know any stent specifically designed for transverse sinus, venous sinus stent, and a reverse stent?
Yeah, nice presentation. I'll tell you one or two things and what we face. And if a patient is rapidly losing sight, what will be your approach? This is very important. The other thing is that the site of stenosis is also very important. Whatever cases you have junction of transverse and sigmoid. And if your stenosis go towards the proximal part of the transverse, or at the junction of the supraparietal sinus, and you have to reconstruct the whole of the sinus. So otherwise, what happens? In one or two cases, my personal experience, what I am telling you, once you stand, immediately you will see stenosis is extending to the proximal because the intracranial pressure is very high. That's why we do not know what is the cause of stenosis. That the stenosis caused the intracranial hypertension or vice versa. So that is one. Three cases we had to do associated VP shunt. VP shunt doesn't work for a long time. And then only it was extended. We had to do 2 or 3 stents and all that. And also we saw proximal to the pressure gradient is developed. So in those cases, what I feel, all these cases, they are telling, they are rapidly deteriorating. So I feel in those cases, better choices would be go for a VP shunt. Once I put the stent, to stop and coagulation and then put VP shunt. Why did you stop? It can go along with that.
Yes, that is the ideal scenario is that acetazolamide the pressure comes down to assess
your acetazolamide is not suppressing the CSF formation. So there's no point stopping it because it might it can add it. Another is single antiplatelet and anticoagulant. The formation of it's not like the arterial use one. So you have to use one anticoagulation, one antiplatelet. The literature says like that. It's better to do that.
So we also had a similar case wherein the stenosis was at close towards the proximal transverse, wherein we completely reconstructed the superior sagittal sinus. Every time we reconstruct one segment, proximal segment was increased. This was like two-stage procedure where we did the stenting. Pressure came down. Within 3 days, patient again developed. We went back again to see the pressure is increased. We reconstructed the whole then again third day came back the same. This is again a case of fulminant IH. But this patient was diagnosed later with cryptogenic meningitis. That was the reason for all that treatment. Post that treatment, we recovered and further procedures, manometry later after 6 months was completely normal. No pressure gradient at all.
Another point. When you see the CSF opening pressure is below 20. If it is below 20, then probably the stenting is very high. CSF opening pressure is going 40, 50. You should go for direct VP shunt.
Thank you, sir.
Thank you. Next, Dr. Chirag.
Thank you. A very good morning. The entire purpose of So the purpose of taking this to generate the enthusiasm for another component of your training, which you should inculcate in your daily life. So this AI-based multi-level residual dual attention network for major cerebral segment, aneurysm, automatic detection, segmentation of aneurysm, which we did as a project from the Department of DBT, Government of India, and Government of Australia. Unfortunately, my fellow could not come here, so that's the reason. So SAH, you all know, has the potential to cause devastating consequences. Accurate detection of an incidental cerebral aneurysm on MR angiography so as to define and prevent catastrophes related to its structure. In SAH, prompt identification of its commonly aneurysm is important to institute prevent its rerupture. However, at times, human shortcomings and atypical aneurysmal characteristics, small size, atypical location, variant morphology, may lead to unacceptable inability to identify these aneurysms. Forget about treating them. Morphologically, you don't really know where the neck is. You don't really know how much circumference of the artery is involved. In this case, you don't really know whether it is dissecting or saccular. based on the morphology. So these are some of the parameters like in this case who had there was spasm here. It was very difficult to identify aneurysm. Eventually a 3D DSA helped us in recognizing. So the entire purpose is to whether these algorithms can identify aneurysms better than a neuroradiologist. Also, AI has caused deep inroads in medical practice, positively transforming it more so in the field of radiology. And AI-based machine learning and deep learning algorithms have the potential to interact in detection of pathologies leading to better patient outcomes. So artificial neural networks and convolutional networks-based coding algorithms are being developed to identify, segment, diagnose and classify various medical disorders. So the aim of this was to utilize AI-based multi-level residual attention network segment several major cerebral arteries, including the circle of Phillips, and to detect, define, and segment cerebral aneurysms. So this was a part of the generalized strategy that we are working on. The ultimate aim of which is to develop an automated pipeline for establishing comprehensive abilities to detect and quantify including detect its positive factors, and other factors, define aneurysmal morphology, and develop tools to elaborate its special details so as to numerical outcomes of these patients with endovascular treatment. So after obtaining institutional subjects harboring cerebral aneurysms enrolled for training datasets, while another 24 testing datasets. 3D time of flight angiogram, MR angiogram were obtained using Phillips Medical's and all the datasets were anonymized before they were shared with our fellows who eventually coded these. So once we took the DICOM formats of 3D to MR angiogram, we transferred it to a platform which is called the 3D slicer. The neuroreannotated and labeled the circle of Phillips and aneurysm. Few of these data sets were transferred training algorithm, and all were subsequently transferred to the testing interface of the code step. And all these results were verified by neuroradiologists. So this is a general protocol that is followed in the training dataset interface. Take these MR angiography volumes, generate the images, and what the algorithm does, what the code does, kind of take patches within the center part of this break it into numerous small algorithms and patches. This eventually undergoes through this network, which in our case for the level residual unit facility. And these are eventually transformed by process of deconvolution and reconvolution, where all the learning happens within these. And these eventually patches are obtained, fused together to generate those images and identify the anomaly. So these are some of the networks. This is the gold standard that was annotated it. So there was a stenosis. But you see in most of these algorithms like unit, attention, residual unit, this is not really being picked up. However, this network we used in this actually helped us in picking up and close to the gold standard gave to the algorithm. So the results, if you see here in aneurysm detection were also so more than 70 to 80% of aneurysms could be obtained. And unlike the other quantification parameters that we use in our analysis of other pathologies, in this particular algorithm, these are the four questions that we use. One is the dye similarity, measures the overlap between the predicted segmentation, which the code and the ground truth, which we have. 95% is cost of this measures maximum distance between boundary points of the predicted segmentation of the codes and the ground. Precision, which is proportion of correctly predicted positive regions of the entire area to which we have given out of all the predicted regions, while recall is the proportion of correctly predicted positive regions out of all actual positive. So if we see in the proposed network, the DSC dice coefficient was approximately 94, much better than all the previous algorithms. And Hounsfield distance distance also was significantly less. That basically means that we are in a better accurate zone as compared to the previous networks that were being used previously in the identification of these. Just to reiterate another table. So I would conclude by saying multi-label residual network perform better than existing networks and these are all international validated, and the NV could achieve a very high DSC of 94%, lowest HD of 11.25, and variably good, I would say, the network is capable of both local and global leading to precise segmentation with smooth and minimal errors. By providing detailed morphology, these network models radiologists to make quick informed decisions and may also be beneficial for treated patients, especially endovascularly treated, which we know are prone to higher recurrence rates. So we obviously can run at a certain speed. AI networks are faster than us, but if we kind of understand these networks, we can actually go places. So these are some of my references. Thank you.
Excellent and latest trend. The trend. What is going on? Sir, couple of doubts actually we have. So suppose you want to commercialize it. You want to put it in a platform where people can use it. So what next? More things you have to do. Like you have done 150 patients. So like more honest data, give more accurate output, something like that. So first thing. How you calculate the sample size going for commercial? And second is what are the confounding factors which can false negative values of these AI models?
So very apt question. Unless it comes to the clinics, it is just paper publication. But it is coming to you. So there are certain fallacies. Our data may be different from your data. So what we need to do is we need to get data from multiple scanners so that we can have the codes are actually trained on multiple scanners. Obviously the accuracy. The second difficulty that we are facing previously we did in brain industry part, which is a problem. Why? Because medical institutes, government institutes, it's very difficult to kind of handshake with the. So now the DBT has really provided platforms in which we can actually take. So once we prove that our algorithm is working, industry can work on generate to a level that eventually useful for. So that is one setting. So that the other question was fallacy. The major fallacy is the person who is doing the marking the data, annotating the data. If the data is wrong, obviously the generation of will be models. But I must say that handling of the data marking, these models are very good to identify. And the accuracy that is provided is stupendous.
We are planning for MRI diffusion stroke detection in our. So we applied for ICMR. So let's see if we do something.
That's very nice. Thank you.
This is done primarily or you are collaborating with some IT?
We are collaborating with the IT people. The IT people. So we exchange fellows. Our fellows go there. They come. So that's all.
Right.
But obviously, I don't expect people to learn. But you should know that it is possible. And you have to take youngsters have to take it forward. IT guys coming to us and asking for justice.
Absolutely.
Thank you.
Thank you, Dr. Chirag. Next is Dr. Shikhar. Dr. Utsav, please be ready. And followed by Dr. Aditya. Dr. Aditya is here for the neuro intervention. No? Okay. Then we have two more candidates. Followed by Dr. Shikhar, followed by Dr. Utsav.
Good morning, everyone. I'm Dr. Shikhar. I'm Dr. Shikhar, resident at BMC and Subteaching Hospital. I'll be presenting on the topic of biology, correlation of clot complexity, technical complexity in mechanical. The study was done. The study was done of Dr. Chirag Jain, Dr. Tawani, and Dr. Charu Parasi. So the outcomes of mechanical thrombectomy despite the patient having similar angiographic and the best of our techniques. So our little study tried to find out the fundamental cause behind this problem. So for a revision, the clots are basically divided into two types. The first is the RBC rich clots, which are characterized by loosely arranged fibrin RBCs makes them soft and deformed. So these are generally seen when the patient's underlying atrial fibrillation or left ventricle fresh emboli can form and then travel to the cerebral circulation. So these clots can show hypertense sign on the presence of iron hemoglobin and on susceptibility imaging they can show susceptibility on MRI because of the presence of deoxyhemoglobin. Because of their nature of being soft and deformed are easier to retrieve. On the other hand, we have the white fibrin rich clots because these are formed because of the structure of fibrin and platelets tight cross-linking figures, which is factor. So in this video that we can see that the RBC is having lesser friction as compared to the white clot, an increased friction with the surface that can cause increased complexity from the vessel. From the common sources, for white clots are large artery atherosclerosis and in patients with ICAD. There is no specific feature that can be seen in fibrin-rich clots. The absence of hypertensive artery sign can be a soft sign for the presence of fibrin clot, and that helps us to plan the mechanical. So these are the mechanical thrombectomy. The retrieving of these clots during mechanical thrombectomy is often complex because of the firm and elastic structure. Clots can fragment and resist conventional often necessitating the use of aspiration or combined to achieve successful thrombectomy. So broadly, the difference between the fibrin-rich clot and RBC clot is that the fibrin-rich clot is mechanically they are more resistant to thrombolysis and they are often associated with longer procedure times. So why does this study actually matter? This study helps us to explain that why some clots, despite having good technique, helps us to correlate the susceptibility hypertense signs with the expected clot behavior. It guides us in the choice of our first line strategy for mechanical thrombectomy. It also helps us look for the relevant etiological work of the patient. So this is what we did. So we really analyzed anterior circulation large vessel occlusion patient over a period of 2 months. Underwent microscopic RBC quantification. The procedural value on site recanalization time, the number of passes required, and the technique and the NIH were correlated using the Pearson and Sperman correlations. So the correlation with the clot clinical parameters was as follows. The older patients tended to have RBC. There was no significant consistent association with the gender due to small sample size. In severity, the proximal occlusions were more fibrin-rich as compared to which were distal occlusions which were more RBC-rich. There was no meaningful association established with the NIJ score. In procedure, the fibrin-rich clots required multiple retrieval attempts. The higher the fibrin content, there was increased reperfusion time. In technical clinical contents, the fibrin clots often required combined techniques for retrieval as compared to the RBC which were frequently retrieved with aspiration anode. So in technical complexity, the fibrin-rich required more device and longer onset to recanalization. In one of our interesting case, it required passes, and the fibrin in that was content in that was 80%. When the clot was sent for histopathological examination, we can see that is having few RBC areas, and the red areas and the fibrin is predominant. And the intima and the media of the vessel was adhered. So basically, the clot was so much adhered to the vessel that it required 8 passes for us to retrieve that clot. So for key correlation, the fibrin correlation, the fibrin inversely correlated with the oxygen side. Higher fibrin proportions were seen in the proximal segment, and the RBC plots were seen in the distal segment. So this was the onset to retrieval time that was seen. So we can see that the fibrin with 80% was showing 434 minutes from onset to the recanalization. This is the correlation between the fibrin content to the occlusion side, and we can see that RBC clots was seen in the superior division of the MCF. So one of the cases in this we can see that there are more areas in the HPE. Clot composition was 40% RBC, 60% RBC. The first pass to recanalization time in this patient was minutes, approximately and the 2 minutes. That was required was only aspiration. As compared to that, we can see that there are maximum areas are seen. Fibrin was 90% in this case with only 10% RBCs interspersed between. The first pass to recanalization time in this patient was 102 minutes. The technique was guided catheter. So we have already seen this. The imaging and the hypertension, basically the hypertension and the blooming artery sign and the blooming artifacts are more related with the RBC dominant. Absence of hypertension sign can suggest that a patient might have a fibrin predominant clot. So the comparison between our data that is already available, so we can see that the RBC clot time was faster time, also seen in our case. The fibrin clots longer times, which was also seen in our study. The occlusion side were fibrin rich in our study as well. So our data reinforced that prior large stage findings that clot biography alone, not angiography alone, drives the thrombectomy even in the small cohort. That so for a representative case, there was a 40-year-old patient with left-sided weakness. The NHS score of the patient was 6. Of onset to arrival at our hospital was 141 minutes. So the first pass to recalcitrance time was only the hypertension. We can see a hypertension artery sign in the right MCA. The occlusion is also seen on the angiography, and this was the clot that we retrieved, and clot composition was 40% fibrin with 60% RBC. Here we can see that the clot is seen in the right MCA. Only aspiration was we have a very good canalization post that. So the clinical takeaway is that clot biology is the determinant of procedure difficulty. So fibrin might benefit from combined or aspiration alone is effective for RBC dominant clots. Conclusion, the clot composition significantly influences the thrombectomy complexity. Understanding the thrombus biology in our precise endovascular therapy. Thank you.
Nice presentation. It's well known literature that fibrin-rich clots can be. What will be your go-to strategy based on CT angio? Now you have seen this retrospective. After learning from all this, you encounter a case with not having a hypertension. That change your.
So we can keep additional tentativas in backup as well. At least because stroke is a emergency case, and the patient at least coming to us have a financial problem as well. So basically, if the hypertension artery sign is not present, we can at least have the thought that retrieval can be difficult. We can at least keep the tentativas for backup. One aspiration we can give with the large catheter, and if that is not there, and then we can go additional attempts with stent retriever.
For us, if given a choice, we would like to go both together. Because this RBC stent retriever, there's a chance of
BTC should be used for proximal.
There are financial constraints.
Yes, sir.
We may have to limit some.
Yeah, Nice presentation. Nice presentation. So we can see that there is a lot of variability between the techniques. Institutions they use aspirations, stand and some use bones. But the usage of the balloon guide catheter is very less actually. They don't use much of because of the complexity of the usage. So did you encounter any intratheranosclerotic lesion? In those cases, white clot.
There was one case with ICAD in that patient, and that came out to be a fibrin clot as well.
So what do you think? What is the origin of?
So basically, the thrombus rupture can be the origin of the ruptures, and then the clot is formed in that artery only.
So a majority of the cases, probably there is some sort of an atherosclerotic lesion either in the neck up there. So that is main reason for all this. In most of the centers, I feel the combined expression, that is technique. Thank you so much.
Thank you, sir.
Thank you, Dr. Shikhar. Thank you, Dr. Shikhar. Dr. Utsav. You have Dr. Aditya Ajit here? No. I request interventional oncology presenters to be ready with their presentations. We will start it in another 15-20 minutes. Thank you.
Very good morning, everyone. Today I'll be discussing trans and underrated route in the era of radial dominance. I am Dr. Junior Resident PGH Chandigarh. My guide is Sarfaraz Ahmed, PGH Chandigarh. So transfemoral artery has traditionally been the standard intervention for senior intervention. But due to increasing radial access is increasingly favored due to better recovery and faster complications. Fewer complications. Despite advantages of trans may be limited by small vessels where anatomic variations in the radial artery. In those cases, trans under access has emerged as a alternative voice not visible and maintaining the upper limb. So we had conducted a retrospective study from January 2024 to December 2025. We included around 9 patients, male and 3 female, and clinically indication and procedure type, whether it was a diagnostic or interventional. Radiologically, we have checked for diameter of radial artery and ulnar artery, patency and target vessel. We have used ultrasound guided puncture and DSC for completion of the procedure. 4 to 5 French catheter for diagnostic and 6 French for therapeutic. Success-wise, you have checked technically the procedure, completed the procedure, was there any crossover to clinically we have checked there was any access site major complications. So we had included patients under diameter of 1.8. Right ulnar artery was favored over the arm was positioned 10 to 15 degree from the body with hand in supination extensions. Monitoring equipment essential dark drugs and pulse. We did not do modified Allen stents in our institute. So after ultrasound guided puncture and CT, we have given cocktail of nitroglycerin heparin to prevent any spasm. After completion of the procedure, we have done a radial compression device to achieve hemostasis and instructed the patients to limit limb movement for next 2 hours. So this is the case of 67 years diagnostic cerebral angiography for a ruptured AVM. Here transalnar access was taken due to radial artery and we could finish the procedure in less than 17 minutes, which is mentioned here. And this is the second case. The 46-year female therapeutic cerebral angiography due to cerebral vessels. Transalnar access was radial diameter. Here also we could finish in less than 9 minutes. We have done 9 procedures out of diagnostic, 7 are diagnostic cerebral angio and 2 were interventional. The main reason for transalnar was small radial artery diameter, and we could finish 9 out of 9 procedures without any major complications. In intra-procedure we had 2 patients mild angiographic and one patient competence of pain but relieved after giving NSAIDs. So transradial artery is considered for a feasible safe why you're thinking of trans. In some cases, as I already mentioned, radial artery anatomic variants like loops, toxicity and high perforation, in those cases, you have to think of alternative upper limb. Here is a patient of 45 years who present with a severe pain after diagnostic catheter to the radial artery. The second case presented anatomic variant of radial artery. Third is a brachial artery where origins high up from brachial artery or even can origin ciliary artery. In those cases, you have to think of alternate axis like transalnar axis. There are many advantages. There are also advantages. We have lower incidence of vasospasm as adrenergic receptors, lower arterial occlusion rate, and favorable. And limitations we have steeper lining. Ulnar artery is deeply located and it's difficult. And obviously we do have limited literature about this. So here I want to mention we have done a lot of trans in our institute of radial access, and we have published many literature. I have to show you here. So you have to mention steeper learning curve is present in trans, but operators who are familiar with trans radial axis, it can have a smaller learning curve. So these are the recent literature which shows about transalnar axis, which shows near 100% success without any major access complications. And our study also is mentioned here. So in conclusion, transalnar axis of comparable technical success with minimal complications. Unless artery stated provided and TRA may have a shorter learning curve for the operators familiar with TRA. And we are not trying to prove that we can replace transradial axis. But if transradial axis is not feasible, we can go for transalnar axis. I'm maintaining the upper limb approach. Thank you.
Thank you, Dr. Utsav.
Nice presentation. One case you have shown that radial artery was occluded. Okay?
Yes.
And then you went for the ulnar.
Yes, sir.
Okay.
Yes.
So in that one, why you went for the ulnar? If the ulnar gets damaged or your dissected or it gets occluded, and the limb will be in problem. No? So why don't you go for the opposite side or go for what is the rationale? Other I understand.
We wanted to maintain the upper limb approach.
It is more than the safety of the patient.
Here this case. The hand perfusion was good. We wanted to maintain the upper limb approach to prevent infection to see if it can do good for this.
Sir is asking that why you want to maintain the upper limb and have that from the left side also. Do you know literature? If radial artery, is there any literature that if radial artery occlusion is there, do not use ulnar access, or both are small then don't use?
I didn't get you, sir.
Is there any literature that if one of the arteries occluded, then that is occluded, then do not use a ulnar artery?
Yeah, it's mentioned in
literature.
No, sir.
Actually, in literature, it said that the hand has very good lateral circulation. And even if one artery is small or occluded, also you had shown that it can be not actually contraindicated. Yes, it can be avoided and can be done from the left side.
Thank you, sir.
Thank you all. The neurointervention paper presentation session is now. We will proceed with intervention oncology. Thank you for the juries. Who was chaired for the neurointervention session. Thank you, sir. Candidates with the intervention oncology can bring their pen drive to upload the PPT. Hello all. Good morning again. Good morning again. We'll be going ahead. With intervention oncology. List will be as follows. List will be as prepared accordingly. Please be prepared accordingly. Dr. Amrin, Varun, Dr. Payal, Dr. Gopika, Dr. Abrar, Dr. Pooja, Dr. Mahendra, Dr. Apurva, Dr. Vaibhav, Dr. Prabjot Singh, Dr. Anurag. I hope all of you are here. And you have submitted your presentation. Thank you. We will begin shortly. We will begin shortly. with the permission of the jury, I'll be starting the session. First will be Dr. Amrin. Please come. Followed by Dr. Prabhojit Singh. Please come to the front line. And have your seat. Then followed by Dr. Varun. Sir, we'll allot 5 minutes plus 1. We have 11 candidates, so 5 minutes plus 1. Question and answers. 5 minutes for the presentation. 5 minutes for the presentation. Plus 1. Yeah, it was 8 because there were less candidates. Now we have 11 candidates for the same time. Agree. So it has to be timing based on number of candidates. Sorry about that. Okay, we'll go ahead with the presentation. It just goes to the other screen. Anna, move.
Good morning, everyone. I'm Dr. Amrin, data from Guys and St. Thomas's. So I'll be talking about fluoroscopy-guided tracheobronchial stent placement in central airway obstruction, single center experience. No conflicts of interest. So a bit of background. Tracheobronchial wide stenting is basically an effective radiation strategy for central airway obstruction, especially in patients who have malignancies that involve the carina and the distal trachea and the main stem bronchi. The compression can be extrinsic or helps to alleviate symptoms of dyspnea, improve the quality of life patients more often than not, and it can be used as an adjunct for laser ablation, dialtherapy, and for management of endoluminal lesions. Before we go ahead and delve with the topic deeper, it's always good to touch base how it all began. It started with simple silicon stents, as we can see here. That's how the procedure initially began. And it was usually done through a Montgomery tube, a picture of which you can see on the side. But these stents were not very flexible. They were difficult to track. The migration rate was high. The reocclusion rate was very high. Then came in the SEM stent, the ones that we place everywhere in the body in IR. Similar to those with silicone covering or without the silicone covering. They are much easier to track. If you use the covered stent, then the tumor growth is much less in these cases. So what we did was from a big cohort of patients, we selected out 21 patients who only underwent the Y stent placement in the last 6 years. The multidisciplinary team included interventional radiologists, and anesthesiologists. Inclusion criteria inoperable malignancies, or post-surgical complications, and also patients receiving concomitant radiotherapy or chemotherapy. IR is all about innovation. Small to big, that little clip there, which you can see is the U clip basically, which is available everywhere. I'll just tell you why we use it and where we use it. What we do is a combined procedure with bronchoscopy and fluoroscopy. So we have the general anesthetic, we have the respiratory team. They put in the rigid bronchoscope. We mark the carina at the bifurcation. The C-arm comes in. We do a fluoroscope, place the U clip just on the chest and tape it to the patient's chest. So it's more like you're completely trying to be field-proof, where you have a landmark on bronchoscopy and you have the fluoroscopy landmark. The bronchoscopy also helps in facilitating mucus removal, biopsy and ablations as well. Patients usually undergo stenting with chest X-rays and chest X-rays performed at 24 to 48 hours to look for expansion in position. The complications that we evaluated for were migration, patient tolerance, perforation and stent. Now there are lots of stents in the market. The one that I'm going to be talking about is just on how we do it and what this basically Y stent means. So if you see the stent design, if this is working. Okay. Yeah. So if you see the stent design. Okay. So what I want to show you is the blue colored marker and the white colored marker there.
You can use
Yeah. So the blue colored mark and the white colored mark and the white colored marker, each of them signify the right and left bronchus, which is very important when you're doing any sort of a bilateral. You need to know which wire is coming out from which port, coming out from which port, and which part is what you're deploying first.
The part basically has a blue and a white marker there,
and then you have a white and then you have a white and a blue marker at the end. So the white represents the right side and the blue represents the left side. Now going forward, what happens basically in this procedure is, so you've identified the lesion at the rigid bronchoscope comes in. And then you use your standard J wire, hydrophilic wire, and a catheter. That is the small U clip that you see of the carina. You cannulate each of the right and left main bronchus with hydrophilic wires. Once you've done that, you exchange it for stiff Amplatz wires. Once that's been done, an image showing that. But you need to remember that the right and left, you need some way to identify which wire we usually have tapes, red and blue colored, which keep on that this is the right and that's the left wire. So you see how it has two catheters with the whole thing goes and the whole thing goes on two different wires down. You place it like a centimeter proximal. You have your clip there, which is telling you where you are. Ensure that that doesn't happen. You have to detangle it, otherwise that will otherwise end up in an inappropriate deployment. Then what happens is you basically advance the two limbs, and then do a gentle forward tug, and then independently. So that's a gentle forward tug, which is important that you that's a technical aspect of what the procedure is. And then you independently deploy each of the ports. That is what happens. That is what you finally deploy. Once you're happy with the deployment, deploy the whole bit of the stent. So that's the last bit of unsheathing. So that basically in a gist is what a wise stent is. So this is the first patient. This is the 50-year-old gentleman who's come with obstruction, more on the right than on the left. That's how the stent has been placed. This is another fluoroscopic image which I wanted to show on how the whole stent works. I'm not showing apologies for that. Apologies for that. But what I wanted to show here, is separate deployment of the two limbs. That little U pin is at the crinal bifurcation. So you know you've deployed the two limbs. You come up happy with the placement. You're happy with the placement, and you deploy the main stem of the stent eventually. So technically that's the procedure. This is another patient. You can see the chest X-ray. You can see the chest, the malignancy, mediastinal mastinum, posterior mediastinum, lots of compression. So in this particular patient, we decided to go with a wide stent. Sometimes the easiest stent to track, like you saw, it was a bulky system. So we couldn't track the whole stent apparatus. We had to take it back. And then we had to deploy.
Time's up.
In the last minute? Okay, I'll just go to the last slide then. So 18 and 20 millimeter diameter, just some take home messages on what prognostic factors would be distal airway patent. If that is present, then prognostic factor. Technical success being 95%, procedural complication rate being 7%, only in one patient couldn't tolerate it, so we had to take the stent out. Good response, so we didn't have to put another stent in. Multiple studies that say that safe procedure can be performed in a multidisciplinary setting. Future prospects stents, biodegradable stents, and radioactive stents with 125, which have good potential to inhibit the persistent growth in malignant tumors. Those are the takeaway messages. What I would say is not procedure, very challenging. A little bit of a learning curve can be safely performed by IRs in combination with respiratory physician and anesthesiologist. Happy to take any questions.
Predict that the outcome will be the. Of course, you have pointed the distal airway
distal airway disease and plus if the patient is technically I would say if the distal airway is patent, that's a good sign that the wide stenting can be done. It's not a tight stenosis. The very tight stenosis will not track. We will have to do separate kissing stents. Is there anything else?
What about
there any difference between external or internal tumor, let's say tumor, or it is any difference?
Trackability will be very poor if it's intrinsic.
Asking about the
Clinical outcome. Extrinsic, I think, respond better. I don't have vast experience in it, but the ones that have extrinsic compression respond better than the ones who have intrinsic endotracheal disease.
Of course, the patient
Yeah.
performance.
Yeah.
Just tell me the early and late complications of.
Early complication would be patient didn't tolerate it on table at all. Inability to track perforation while you're trying to do it. Would be stent blockage, stent migration tissue, granulation tissue, and those are the ones that come to my mind.
Procedural bleeding, what about bleeding, how do you tracking the ear, going through the tumor,
Yes.
how are you managing aspiration from distal
We've not had terrible bleeding in any of the cases that I have seen and been a part of. But in my understanding, if there's a lot of ballooning, we have the advantage of bronchosuctioning. You do suctioning, we can do a balloon tamponade. You can selectively put balloon in one lung, which is selective ventilation to the other one.
Are you doing it? Are you needing it regularly?
Are we needing it regularly? As in you mean complication-wise? No, never, no. Thank you.
Thank you, Dr. Amreen. Dr. Next is Prabjot. Please note it's OP20. It's in the second sheet. OP20.
A very good morning to all. I am Dr. Today I shall be presenting our retrospective analysis comparing the planned versus achieved following percutaneous microwave ablations for liver lesions. So as you all are aware, microwave ablation is an integral component of locoregional therapy and metastatic liver malignancies. And in routine practice, accurate pre-procedure planning relies on manufacturer-provided reference dimensions, which are typically derived from ex vivo or healthy animal models. However, real-world ablations are performed in fused human livers. There's heat sinks, there's tissue heterogeneity, and all of these factors ultimately influence the final ablations. Therefore, this study was conducted planned versus achieved at 75 watts and 100 watts, and we examined whether discrepancies differed between the two wattage groups. So ours was a retrospective match comparing 75 watt microwave with the retrospectively selected and matched 100-watt cohort. Now the two groups were matched for lesion location size, the CTB score, and proximity to major to minimize the confounding. All ablations were performed using the imprint microwave ablation system. Each lesion being treated with a single ablation. And in total 18 ablations were analyzed, 9 each in the 75 watt and the 100-watt groups. So as far as the measurements was concerned, the planned ablation dimensions were obtained from the manufacturer reference, whereas the achieved ablation length were measured on immediate post-procedure using multiplanar reconstruction along the axis of the insertion microwave antenna. And this is how we made the measurements by also we excluded the zone of hyperemia on these immediate post-procedure images. And the percentage of discrepancy was calculated by subtracting the planned zones divided by the dimensions and multiplying that by 100. So we focused on two primary metrics, the relative length error and the relative width error. Agreement between the planned and the achieved values was assessed using intra-class correlation coefficient analysis and the differences between the 75 and 100 watt groups evaluated using the Mann-Whitney U test. So this is a table summarizing the baseline characteristics of our study. You can appreciate both the groups uniform in terms of the patient age, the lesion size, the lesion type, location, as well as the proximity to major vessels. So this is the data of our 75 watt. This is a busy table, but what I want you to see is the percentage discrepancy that desired versus the achieved ablation and length. If you compare it with the discrepancy in the width, you can see that there is a stark difference between the two with the discrepancy significantly higher in the width as compared to the length of ablation zone. Same findings are also in the 100 watt table. So, to analyze this data, we use two complementary methods. On the left is comparing the planned versus achieved measurements. The diagonal line that you see is the line of identity. The machine was 100% accurate. Every dot would sit perfectly on that line. On the right is the bland ordinal plot, and unlike the scatter plot, this gives you an objective measurement, and it tells you how much the machine is missing the target on a mean basis. So, if you look at the length, the system is remarkably accurate. You can see almost all the dots hugging the line of identity. And even on the bland ordinal analysis, you can see that all of these dots are within 0.1 millimeters of the expected zone of operation that we had planned. Therefore, we had planned a very tight agreement between the two. However, when coming to the width, the results here are reveal a significant clinical problem. So every dot that you see below the line on the represents a patient where we achieved less than what we planned. That is 17 out of 18 patients. And the bland ordinal analysis again mean by that there was a mean bias of almost 7 millimeters, stating that on an average we were missing out by approximately 7 millimeters. So that was the most major finding of the study that we found. And also the max limits of agreement were pretty far wide, ranging from -1.41 to 0.5 centimeters, and with the maximum deficit of -1.4 centimeters, stating that there is a significantly higher risk of marginal recurrence in these patients. So finally, we used the box plot to see power settings could mitigate this. So while our p-value was 0.11, the visual trend is that at 75 watt, we see a median deviation of -25%, whereas at 100 watt, that error is reduced and the median comes down. So the relevance of this is that although both settings underperform, the higher wattage group appears to provide a more predictable, slightly undersized ablation volume compared to the 75 watts. So the crux of our results is the asymmetry of reliability with the M-print microwave. A few studies have been published, and this was one of them. Again, using the M-print system, they evaluated 103 ablations. There are parenchymal discrepancies. Now the M-print manufacturer available charts that are available either on ex livers or they are wine livers, or they are based on in vivo healthy porcine livers. Human liver tumors, particularly in cirrhotics, altered dielectric properties and increased stiffness, thermally resist the outward conductive spread of microwaves. A third and an important reason is that there is rapid high power heating leads to tissue desiccation near the antenna, and this creates an insulating gas or a charge limit further lateral energy phenomenon more pronounced in the transverse plane than the longitudinal. Lastly, the thermal momentum comparing 100 watt versus 75 watts. The 100 watt gives you more thermal momentum and better overcome the local heat. However, even at 100 watts, the bias remains likely due to rapid tissue desiccation around the probe, again creating that high vapor sleeve that limits further lateral energy transfer. So while our study is limited by its retrospective design, the limited sample size, the lack of subgroup analysis across tumor histology, its strengths lie in the inhuman assessment, the careful matching to control for perfusion-related confounders, a single platform analysis, ensuring technical uniformity, and the use of appropriate agreement-based statistical methods. So to conclude, we found that achieved ablation widths were consistently smaller than manufacturer predicted values, whereas ablation lengths showed good concordance across wattages. Also, the trend towards greater discrepancy between the planned and achieved ablation zone width at lower power suggests a wattage-dependent variation in the in vivo performance, and therefore further validation in larger prospective cohorts is warranted to refine our predictive models, improve the procedural planning, and ensure adequate safety margins in microwave ablation.
Time's up.
Thank you very much. In the end, I'd like to acknowledge the entire IR team back at Medanta, Gurgaon, under the very able leadership of Dr. S.S. Pejal, sir. Thank you.
So the crux of it is that possibly the higher wattage is the better wattage.
Yes.
100 watt is the, which we consider the 80 watts is the sweet spot. It's not actually, it is the 100
Yes.
watt. And so to overcome the problem of the width discrepancy, what suggestions?
So suggestion would be to plan your ablation in a way where you're taking at least an extra 5 to 7 mm of margin. So the routinely, if you're taking just 5 mm, then considering the results of our study, we feel that maybe a further 5 to 7 mm of margin, especially along the width, along the transverse axis of the antenna, would give us better results. And that's how we've been doing it, which is why in all of these patients, even though the ablation zones were smaller than what we had planned, we had actually planned it in a way that was still exceeding the tumor margins by at least 1 centimeter.
So let's say your mean size was roughly about 2.3
2 centimeters, yes, sir.
Let's say 2.5 centimeters. So what ablation zone you want to create looking at your study?
So 3.5 along the perpendicular axis of the antenna.
Perpendicular to the 3.5 will be the ablation zone?
Yeah, 7 mm this side and at least 7
But I
mm.
think that will not.
So
that will
5
not
plus 7, so 1.2 and 1.2 actually.
So you're saying 2.5 is the tumor diameter.
Yes, sir. So 7 mm here and 7 mm here.
But
3.9.
Still, we are not reaching the concept of A0 ablation of 1 centimeter.
So A0, whether we take it 5 mm or 1 centimeter, I think that's still debatable. Yes, preferably 1 would be the better ablation margin, but yeah.
So in usual, what your planned is roughly about 5 millimeter margin when you plan the case?
Yeah, 5 millimeter, and we exceeded by almost 7 mm based on these results, especially if we are doing it at a lower wattage.
Okay, so you have in this study planned 5 millimeter on both sides in your study, and now you are recommending to increase to 7 mm, you are saying?
No, sir, since this was a retrospective analysis, we had, at this beginning, we had planned a larger ablation zone, which is why we didn't get the recurrences or the residual disease in these patients.
Right. So what I want to ask, now if you have to plan a 2.5 centimeter.
Yeah, now we would add the extra.
So what ablation zone you plan when you do the ablation now?
Yeah, so now we plan it with these results, keeping these in mind, and we plan for an additional 7 mm margin on both sides.
That means total
1.4.
Total width of the ablation?
Yeah.
Total width of the ablation, I am asking you.
Okay, so that will be the size of the lesion in the transverse plane plus 1.4.
1.4. So
yes.
Let's say 4 centimeter.
So the maximum ablation it gives is 4.2, I think. Even if you keep 4.2 is rating 100 into 10, I think we get a 3.5 centimeter ablation or something like that. Right. So my question was, because of your study, nobody has got a recurrence, right?
Yeah, so recurrence rate was nil in
because of your study.
Yeah. Thank you.
Thank you. Dr. Varun Yadav. Please be ready, Dr. Payal Sharma. Please be ready for them. So we are back again to the schedule, the list we have, OP12, esophageal stenting redefined.
Good afternoon, everyone. My topic is esophageal stenting redefined, expanding horizons with fluoroscopy guided approach. So malignant esophageal obstruction causes severe dysphagia, malnutrition, and poor quality of life. Palliative stenting offers rapid relief of swallowing difficulty and improves nutritional intake in these patients. Also, it helps in closing down fistulas or leaks, which are commonly seen in advanced esophageal lesions, thus preventing and treating recurrent respiratory infections. Although endoscopic stenting is widely practiced, Fluoroscopy guided approach provides comparable efficacy and several advantages such as real-time visualization, reduced procedural time, and reduced need for general anesthesia or deep sedation. This makes it an ideal approach for these high-risk or debilitated patients. The purpose of our study was to assess the safety, efficacy, and quantitative improvement in quality of life following fluoroscopy-guided esophageal stenting. This is a retrospective observational study with a sample size of 19 patients who presented to our hospital in the past 2 years with malignant esophageal obstruction and underwent fluoroscopy-guided covered SEMS placement. All the palliative patients with severe dysphagia or esophageal fistulas or leaks were included in the study, and patients with incomplete records were excluded. All procedures were performed in the cath lab under fluoroscopy guidance. A nasogastric tube was inserted a day prior to the procedure, if not done already, and all lab parameters were checked and optimized. A single-shot IV antibiotic was given, and either sedation or sometimes general anesthesia was administered before the procedure. So the patient was laid supine, and a shoulder bolster was placed to extend the neck. Their jaw was opened using a jaw retractor. The first part of the procedure was done under fluoroscopy guidance, where we gained access into the stomach via the stricture using catheter and hydrophilic guide combination. And after that, we did esophagogram. And finally, the stent was placed with the operator on the head end of the patient because that made the angles more convenient. So covered stents were placed under fluoroscopy guidance. Gentle balloon dilatation with large balloons were only performed when there was significant residual narrowing. And a continuous contrast flow across the stent confirmed unobstructed esophageal flow or closure of fistula. So let's go through a few cases. This is a 43-year-old gentleman who presented with dysphagia to solids, semi-solids, change in voice, productive cough. Upper GI showed mass at 20 centimeters with a fistula. However, probe could not be negotiated further. Cross-sectional imaging showed a large esophageal mass with adjacent cavity lung infection in the right upper lobe. So a palliative intent was decided, PAL chemo and esophageal stenting. So we did a gram ourselves, and to document and to know the site of the fistula. And once that was confirmed, we placed a stent such that it covered the fistula as well as the stricture at least 2 centimeter proximal as well as distal. And after stent opening, there was good flow across the stent with closure of the fistula. So post-procedurally, we would keep the nasogastric tubes for at least a day, and the feeds would go through the tube itself. The next day onwards, patient would be slowly encouraged to take food orally, first sips of water, then liquids, and gradually progress to semi-solid diet. And they were reviewed clinically after 1 week and 4 weeks. They were given these written instructions on how to go about with their life, with their dietary habits, to take soft and semi-solid diets accompanied with liquid, sodas, and avoid hard foods, chew their food well, avoid swallowing large chunks, etc. So technical success was defined as accurate stent deployment with immediate luminal patency. Clinical success was defined as improvement by at least 1 dysphagia grade and tolerance of semi-solid food, and complications were classified as per SIR guidelines. A quality of life was also assessed quantitatively using the WHO Quality of Life Brief Questionnaire, and symptoms such as dysphagia, reflux, cough, and pain were also evaluated both pre and post stenting. So let's see another case. Old gentleman, dysphagia. Again, this patient had fistula and severe infection of the right upper lobe. We could see the fistula ourselves on the gram. Usually, I would advise not to push too much contrast. I'm showing this for the academic purpose, but we have stopped putting too much contrast now. And sometimes it is actually difficult to negotiate the wire into the true lumen. Many times it will go into the fistula itself, but with a few attempts we'll be able to get through these strictures because they are malignant, so they're not so hard to cross. So we measure the stricture length and place the stent size accordingly. So we can see that there was good clinical as well as radiological response in this patient. Another case of pulmonary esophageal fistula closed very well with the covered stent. So here the grade 3 dysphagia was treated very well, and the patient was able to take semi-solid foods after stenting. This is a case of lower esophageal growth with involvement of gastroesophageal junction. So here we placed anti-reflux stent, which has a mechanical valve at the distal end, which ensures food passage through in one direction only. So this is a case of esophageal pleural fistula, and here the stricture length was quite large. It was almost 10 centimeters, so we decided to go ahead with a 15 centimeter stent. We could not place it too much down because that would irritate the lower esophageal sphincter. So, however, there was on-table stent migration proximally. We tried to gently push it down using a balloon, but it was not going, so we left it as it is. And since the indication was to cover the fistula, we were not so worried about it, and actually there was good flow nonetheless. So all of our patients were old age, 60 to 70 years. Majority of the lesions were in the middle third of esophagus. Almost 50% had fistulas, and 3 patients also had gastroesophageal junction involvement. Technical success was achieved in all patients except for 1 where the stricture could not be crossed, and clinical success was achieved in 15 patients. Minor complications, those seen in almost 1/3 of patients, were usually transient and resolved conservatively. We did not find any cases of restenosis or major events, although we lack long-term data because these patients are quite sick and they don't have a very long survival.
Time's up.
Just 1 minute, please, sir. Thank you. So we can see that there was significant improvement in the dysphagia score and significant improvement in symptoms such as reflux, cough, not so significant improvement in pain. And there was significant improvement again in the quality of life score, which increased by 10 points, almost 30% increase. Our study fared pretty well against previous studies in the literature with a technical success of almost 95%, clinical success of almost 80%, and a complication rate of 30%, but most of them were minor only. And our dysphagia improvement also compared well with the studies. So unique contribution of the study is that it gives a quantitative demonstration of improvement in the quality of life, which had not been done before as per our knowledge. There's few studies which have done it, have only done it qualitatively. The limitations are obviously the small sample size, the retrospective design, and the fact that we have only covered malignant cases. These are, I've just recapitulated the main points of our study, and I would like to conclude by saying that fluoroscopy-guided esophageal stenting is a safe, reproducible, and effective IR-based palliation care method for advanced esophageal disease. These are my references. Thank you.
What are the benefits over the endoscopic?
Sir, so we can completely see the procedure fluoroscopically. Real time, we can visualize the stent opening, the stent placement, we can be precise with it. Also, the procedure time is very less. This takes about 15 minutes. And we can, although if we are getting general anesthesia, we might have to take it as well, but we can also do it without general anesthesia, which might not be the case using endoscopy.
All endoscopic are done in the
no sir.
In the sedation.
They can also do under deep sedation.
So only see the classical benefit is that we are able to evaluate the distal part more clearly. Yes. Once we're crossing it. They just place it looking at the CT scan and regarding the clinical success of 78%. So that 22% includes whether the dysphagia has not improved or the fistula was not.
So dysphagia has not improved. Fistula is closed in all the patients.
Yeah. Any precautions, especially for upper third?
Yes, sir, definitely, sir. So the major challenge you would find is when the lesions are quite high up, because you will have to open the proximal end quite close to the cricopharyngeal junction. Mark that area. We usually do that on CT on the same day or 1 day prior. We mark the area, and we also, if we have an anesthetist on site, and they are able to do a endoscope, a laryngoscopy or something, they can give us the marking on fluoroscopy as well.
So usually, if you have to see just on fluoroscopy, what your
yeah. So the usual markers would be don't go above C7. The cricopharynx is at C6, C7. Don't go above C7 because there is a parallax effect as well when you're looking at this patient on supine. If you think you have gone just above C7 and you get a CT scan, then it would be slightly higher.
Yeah, so C6 lower border,
yes.
definitely C7.
Yes, sir. So people usually come with the complaint of cough at the time of swallowing, which was their original complaint as well. Sometimes it is not resolved, and in some patients it is aggravated as well. If it is, usually we would put them on nebulization using Mucinex. If that is not helping and the symptom is too much to prevent them from swallowing, we would have to eventually place a nasogastric tube. No, on table. Usually they come on follow-up, ma'am, with these complaints. Thank you.
Thank you, Dr. Varun. Dr. Payal. Dr. Gopika is here. Not here. Okay. Dr. Abrar, your presentation next. Please be ready.
Good afternoon, everyone. I'm presenting a study from Tata Memorial Hospital, Mumbai, titled as Safety and Efficacy of Image-Guided Cryoablation in the Treatment of Unresectable Extra-Abdominal Desmoid Tumor. So a short rationale behind the study is that the desmoid tumor are mesenchymal tumor, and the treatment option we have is surgery. Surgery is usually morbid, and many times it is not possible. Second is chemotherapy, which is promising. Sorafenib and other agents are there, but same systemic side effects are more. And the third one is IR, interventional radiology. So the purpose of our study is to evaluate the efficacy and safety of image-guided cryoablation and to assess the local tumor control, pain control, and range of movement in the extremities and complications of the same. So method and material. So we included all the patients with fibromatosis, either recurring or residual after surgery or chemotherapy or hormonal therapy. And we excluded all those patients having a lesion in close proximity to the neurovascular bundle. So a total of 20 patients we took underwent 27 sessions of cryoablation. Our results are like, so a majority of our patients were in the age group 25 to 50 years old, and major complaints were pain and restricted movements. Majority of them, they had a surgery 1 or 2 sessions, and the location was lower limb. So we evaluated, on follow-up, we evaluated the response based on the RACIST criteria on contrast-enhanced MRI, and we got partial response in 80% of the cases, that is more than a 30% reduction in the tumor size. We evaluated the pain by using the visual analog scale. So the pre-procedural mean was 5, which reduced to 2.25 after 3 months, which is significant reduction in pain post-procedure. We evaluated the improvement in the range of movement by using the MSTS, that is Musculoskeletal Tumor Society score. Pre-procedural mean was 19.9, which increased to 23.7 post-procedure in 3 months. Increase in the score is a better outcome. In our cases, we got a reduction in the tumor volume for about 51 to 70%. So overall, there is significant improvement in the pain score at 3 months. The VAS was 5 to 2.5. The P-score was less than 0.05. And the mean MSTS was improved from 19.9 to 23.7 over 3 months. So here's a case of a 9-year-old child who underwent debulking of fibromatosis. So she had a large left gluteal fibromatosis. So in the post-contrast T1 weighted image, we can see there is intense enhancement of the lesion. The fourth image is showing ice ball formation, and the last image is of follow-up, which is showing significant reduction in the tumor enhancement, and there is significant necrosis centrally. The next case is of an 11-year-old boy with right gluteal fibromatosis. There is intense contrast enhancement. The cryoablation was done using cryoprobe, and the last image is just to show that there is some fluid density in the subcutaneous plane. We did hydrodissection. We do hydrodissection in cases where we think there is close proximity of a vital structure like a neurovascular bundle, or to protect the skin from burning. So we had one complication, which was transient neuropraxia of the lower limb, but that too was treated conservatively with steroids and physiotherapy, and the patient improved in 2 days. In conclusion, cryoablation is a safe and effective treatment modality in the treatment of fibromatosis, and it helps in pain palliation and improves the functional outcome in patients with extra-abdominal desmoid. Thank you. These are my references. Yes, ma'am. So basically, we did it for pain palliation and to improve the range of movement.
And then what are the chances of recurrence? And then
there are chances of, yes, ma'am. So there are chances of recurrence. We surely will call the patients on follow-up and assess.
And then redo the procedure?
Yes, if required.
So I think most of these are procedures not to get a complete
Yes,
ablation.
no cure,
These
yeah.
are this, so they will have the residual tumor.
Yes, sir, correct.
The main thing is the functional and the cosmetic
Yes, sir.
improvement, mostly functional and pain.
Ji, sir.
Right. So what is the usual reduction if of the tumor after cryoablation for desmoid tumor?
So we got, yes sir, so we got a reduction, significant
maybe
reduction.
Described in the literature also, you can tell.
Yes sir, so we got a 50 to 75% reduction in 6 weeks. That's what we got.
And what are the benefits over thermal ablation, means heat ablation?
So basically, sir, for all the fibromatosis cases, desmoid tumor, we generally prefer cryoablation over thermal ablation, because we take the patient in general anesthesia only, but we have seen that the bigger the ice ball is, the better the outcome is. So for in cases thermal ablation, we cannot ablate the whole entire area without causing any damage.
Okay. And so usually, let's say the tumors, how much time it takes for a procedure?
So yes sir, so basically it depends on system to system. So what the system we used to use was Boston Scientific. So generally we take a bigger probe, which is a 14 gauge cryo probe, ice force, and generally it takes a 10 minutes freeze, thaw, freeze. So 10 minutes, 8 minutes, 10 minutes. So yes, for
so
one
roughly,
ablation.
So for roughly how much time, all the cases you have shown, what is the roughly mean procedural time?
So 1 to 2 hours, sir.
2 hours. And how many electrodes you generally use for these?
So maximum we used in a case was 4 electrodes simultaneously. Thank you, sir.
Thank you, Dr. Payal. Next presenter will be Dr. Abrar. Please note OP15. OP15. We don't have the presenter for OP14, so we're moving ahead with OP15 by Dr. Abrar. Thank you.
Good morning, everybody. Today I'm here to present strategies for intraarterial chemotherapy in retinoblastoma and difficult anatomy. So ISC delivers high concentration of chemotherapeutic agent into the ophthalmic artery, so maximizing the local control while minimizing systemic exposure. It can be either primary, secondary, tandem, bridge, or rescue depending on when it is given. So the goal here is globe salvage in retinoblastoma, but direct catheterization of ophthalmic artery is not always possible. It may be two small anatomical variants like ophthalmic originating from MMA may be there, or depending on the ophthalmic artery takeoff from ICA, catheterization may be difficult or they may undergo spasm. So this is a retrospective study which included 18 patients split equally between primary and secondary. Parameters assessed were technical approach, fluoro time, number of settings requiring enucleation or any side effects. So basic technique here, it is done under general anesthesia, 4 French femoral access is acquired, ICA angio is done, ophthalmic artery is identified, then it is cannulated with 017 neuromicro, then chemotherapy drug is infused. Most common drug regimen is Melphan 5 mg and Topotecan 1 mg given over 30 minutes each. Triple drug therapy including carboplatin can be used, or high drug regimen can be used based on individual basis. Most preferred technique is the NOVA technique, where the microcatheter is advanced over the microwire beyond the ophthalmic origin. Then microwire is retracted. Then microcatheter is gently pulled back till it falls into the ophthalmic artery. This avoids spasm or dissection. Here is a fluoro video that shows the same. After which angio is obtained to see for choroidal blush and stable catheter position. So whenever this is not possible, we go for other techniques. First is wire cannulation of ophthalmic, then track the micro. Second is PCOM access. Then we have MMA access, utilizing the meningolacrimal branch. Then we have a balloon-assisted infusion, where a neuro balloon is inflated beyond the ophthalmic origin, which helps in flow distribution. Sorry. Yeah. Which helps in flow redistribution into the ophthalmic artery. It is jumping. So, so out of 18 patients, 30 sessions were performed, average of 1.7 sessions per patient, maximum 4 sessions in a patient. So 21 patients underwent no wire technique. Wire cannulation had to be done in 6 patients. 2 patients MMA access was utilized. 1 patient PCOM access. So okay. Depending on origin of ophthalmic artery, it can be classified as just arising from anterior genu, arising from genu and midpoint between genu and PCOM, arising from beyond this midpoint, arising from ECA, and arising from cavernous ICA. Types of regression patterns seen on follow-up are as shown here. 0 means there is no visible remnant, 1 is completely calcified, 2 is completely non-calcified, 3 is partially calcified remnant, 4 is an atrophic scar. 0, 1, 4 are considered to be good, 2 and 3 require more frequent follow-ups. So video there. Okay, fine. The image on the right is a image on the right here is a pre-ISE fundoscopic image showing the retinoblastoma. There's a video there that shows wire cannulation of the ophthalmic artery. This was the post cannulation angio showing stable position and choroidal blush. This below this image, this is the post ISE follow-up image showing type 1 regression complete calcification. So this is another case example of ophthalmic originating from ECA. The image here is the pre-ISE fundoscopic image. This is the ECA angio, which showed ophthalmic artery originating from the accessory meningeal. This is the selective angio showing the choroidal blush and stable catheter position. This is the follow-up fundoscopic image showing type 3 central and type 4 peripheral regression. Okay. Sorry. This is another case example of PCOM access. There's supposed to be fundoscopic pre-ISE image. This is a diagrammatic representation showing the intended access through PCOM. This is the fluoro image showing PCOM access. This is the selective angio showing the choroidal blush and stable catheter position. This was type 3 regression on fundoscopy post ISE. This is the So this is ICA angio showing there's no ophthalmic or choroidal blush seen. This was the ECA angio which showed the choroidal blush, okay, which was arising from MMA. Then it was selectively catheterized. This angio taken which showed the choroidal blush and ophthalmic origin from MMA. So technical success here was described as successful catheterization and complete infusion, which was achieved in 100% of cases. So outcome was categorized based on the regression pattern. Out of the 9 primary, 6 had a good outcome, 3 had a poor outcome. Out of the 9 secondary, 5 had good outcome and 4 had poor outcome. So out of the 18 patients, 4 underwent enucleation in which 3 were secondary and 1 was primary case. Mean time was 20 months from the procedure. Side effects that were seen were retinal detachment, forehead pigmentation, lid edema, vitreous hemorrhage, subretinal clot, retinal epithelial degeneration, occlusio vasculitis. So use of pre-procedure nasal vasoconstrictor usually reduces the nasal spread and systemic toxicity, and ice packs during the procedure helps in forehead erythema post-AC. So average time was 13.9, which was obviously increased during the PCOM and MMA access. Fluoro radiation dose was within 137 milligram. To conclude, it's a robust globe-preserving treatment. Pulsatile or intermittent delivery of the drug avoids reflux and breaks laminar flow. No technique is preferred. When it's not possible, understanding the collateral pathway helps in technical success.
Time's up.
These are my references. Thank you.
So let's say you're not able to catheterize the ophthalmic artery, or there is a spasm immediately after that. So then, what is your flow of action? That I will do this.
First, we take the IC angio, make sure the ophthalmic artery and choroidal blush is there. We go ahead with no wire technique. If it's cannulated, we go ahead with the procedure. If it's not possible, next is and ophthalmic is originating from the ICA, we go ahead and try to cannulate it with the wire. But if the siphon is very tight or difficult anatomy, or ophthalmic origin is very acute, then it's difficult to hook with the standard technique. If PCOM is good, we go ahead with PCOM access. But ICA angio is not showing any choroidal blush or ophthalmic artery is not visual, then we go ahead and see the EC angio. Then we see for choroidal blush. If it's visible and it's problem, then we'll take the access as the angio shows.
So when you use the flow diversion technique?
We haven't had to use the balloon-assisted diversion. It's described in the literature.
Let's say if you have to use, what balloon you will use?
Any neuro balloon. The one described, it was hyperform.
What is the global salvage rate of
salvage rate here was around 78%. Other articles also describe similar salvage rate around 60 to 70%. Outliers were in a study where they included more of secondary cases was very low, up to 30%. And one more study that showed very good result was around 90%.
So let's say the overall long-term prognosis of these patients. So let's say once you get the very good response, what happens in that? What is the natural history of the disease?
So these cases we usually get referred from a tertiary ophthal center. So the data was coordinated between the
according to the literature, what is the natural history of the disease?
They follow 1 month follow-up. They do after every IAC session.
I'm saying you get the complete. So what are the long-term recurrence or anything? What is if you know about the literature?
Long-term recurrence, I'm not sure.
Okay.
Thank you, Dr. Abrar. Dr. Pooja. Dr. Mahendra, be ready for the next one.
Good morning all. I'm Pooja from Sri Chitra Trivandrum. I'll be presenting on a propensity match single center comparison between transradial and transfemoral access for TACE. So it's a relatively small project that we had done recently. So historically, though both transfemoral and transradial have been described for TACE, people have been more comfortable with transfemoral per se, since it's, that's what everyone's been trained with, and it's far easier to do, at least in the beginning. So transradial per se has been gained more popularity because it's more comfortable for the patient, and the recovery times are faster for obvious reasons. However, it has been said to be associated with higher radiation doses. So we tend to, we want to check if that's actually true or not through our study. So these are the aims and objectives. So between transradial and transfemoral axes, we have looked at these 4 parameters and how different they are in these 2 approaches. So for the uninitiated, so this is how we do the transfemoral and transradial axis techniques in for TACE. So the methodology, it is a single center retrospective study done over a period of 4 months, and the Parameters that were evaluated were in axis site complications, fluoroscopy time, dose area product, total fluoro and exposure dose area products, and what was the duration between initial puncture to the celiac artery cannulation, and what was the duration between celiac artery cannulation to the target hepatic artery branch cannulation. So through various literature, we have identified 4 major factors that are affecting radiation doses in TACE. So the patient-related factor being high body mass index and poor breath hold. Tumor-related factors such as multiple lesions being addressed in a single session or a very large tumor size more than 3 centimeter. Feeder-related factors where multiple feeders are addressed in one session or aberrant anatomy is present, and the use of CBCT, which is coming up nowadays. So overall, we have done propensity matching using 1:1 nearest neighbor matching. So, and these are the covariates that we have used to estimate the propensity score: age, gender, number of feeders addressed per session, presence of aberrant anatomy, and use of rolled scan, which is CBCT. So these are the demographic details, and the most common location of the lesion was in segment 8, and 20% had multiple feeders embolized per session, and 20% of the cases had aberrant anatomy. And these were the fluoroscopy time and DAP results overall. So the immediate technical success rate was around 100%, and yes, sir. The total fluoroscopy time, the mean was 1,951 seconds, and the total DAP was 23.57 milligram meter square, and the fluoroscopy DAP was 8.94. So there were no complications that were noted in those in the 60 cases that were evaluated based on matching, and the immediate success rate was 100. So these are the pre-matching results. So basically, there were over 80 cases that were done over these 4 months, 15 transfemoral and 13 transradial. And this is the pre-matching results, and you can see there was significant higher fluoroscopy DAP and in the transradial group, and the puncture to celiac cannulation time was also higher in the transradial group. So the interpretation being transfemoral, it is significantly faster when you from the puncture to the celiac cannulation, and the transradial approach had higher doses. However, after accounting for all the covariates, which is age, gender, number of feeders, the aberrant anatomy, CBCT, the p-value has dropped, and overall an insignificant value has come. So thereby reiterating the fact that the actual difference that is said to be there between both the axes in terms of fluoroscopy time or radiation might not actually be due to the axis per se, and it could be due to various other covariates that exist, which have been identified in our study, and there are many others which still haven't been identified. So just to repeat the same thing, the p-value was lost after the matching, and in fact the absolute values between the transfemoral arm pre and post matching, that means within the 50 cases and the 30 cases, the absolute values in all the parameters remain pretty much unchanged. So the radiation dose, there is no significant difference after matching. However, the overall trends do lean towards faster celiac cannulation through transfemoral axis, obviously due to the shorter distance from the femoral to the celiac artery. And the transradial does tend to have a higher radiation trend, but however it's not significant. And in our study, we also found that there was faster cannulation of the segmental artery feeder on transradial approach. So these are the strengths and limitations of my study. Thank you.
So how do you, let's say retrospectively, you have seen this data, what were the actual factors that this patient should go for transfemoral approach, or this, how it is done in the routine practice, not in the research setting?
So, in the routine practice, most patients nowadays we are preferring to do transradial approach. If after evaluating the proper radial artery anatomy, if it is favorable, we are preferring to do just for better patient comfort and even the access site complications are also since it is relatively better and the patient comfort especially. However, if there is improper anatomy is not good enough for the radial approach, there is severe atherosclerotic disease, then we are going for the transfemoral axis. And also patients who have this higher child score and they have lower platelet count and they are on any other antiplatelet drugs or for other comorbid conditions, we are preferring the transradial approach.
So that is the most important limitation factor of your study, that the age and the atherosclerosis. So the data might not be in a retrospective study. It should be if you do it in the future, it's a good point to discuss. But well done study.
Thank you, sir.
Thank you, Dr. Pooja. Next, Dr. Mahendra. Dr. Apurva is here. Next is yours, Dr. Mahendra. Sir, OP17.
Good afternoon to everyone, and my topic is streamlining SIRT, an initial experience from the tertiary care centers, and that's an interim analysis. Usually the conventional CERT workflow, that's the patient seen in the IR clinic and the patient admitted for the mapping angiography, followed by the SIRT after 1 to 2 weeks. Here we do, in the first setup, we do mapping angiography followed by CBCT, and in my injection was done and the patient sent to the SPECT CT for LSF and TN calculations and the dosimetry calculations. But here in streamlined SIRT, here the patient comes to the IR clinic and we plan have mapping angiography plus the dosage injections at the same day and same setting with mapping angiography and CBCT volume calculations and the dosimetry calculation, the dose injections. What are our primary objectives? Objectives is to see for the feasibility to Y90 in a single session. Secondary objectives is to assess efficacy, safety, complications, and outcome. Materials and methods. So number of patients, we had a small number of patients, that's 8. It's basically a prospective single arm study. What are the inclusion criteria? That's basically it's a child age status of the patients, and within Milan and UCSF extended Milan criteria, patients were included. Exclusion criteria is predominantly HCCs with PVTT and HVT, large intertumoral dysphormic vessels which leads to high LSF, and underlying lung issues with SpO2 less than 90, or ILD patients, or COPD patients, or patients with the prior tips were excluded. Study schemata here, the patient, the informed consent was taken, and the patient was explained about the procedures. The first mapping angio was done, and patient's CBCT was done, the perfused and tumoral volumes were calculated, and activity calculations were done. Here dosimetry, basically we followed a single compartment MIRD study, and the dosage we kept it to beyond the 250 gray planned dose, and LSF was assumed here to be less than 5%, and we used basically a 4-day pre-cal resin macrospares, and the Y90 was injected. The follow-up, clinical and imaging follow-up with the 3, 6, 9 and 12 months. The results predominantly in two subgroups. That's the patients within Milan, the two patients, the mean average size is to 4.5 centimeters, and the UCS of extended Milan criteria, we included 6 patients, that was mean size was 5.4 centimeters. My mean absorbed dose was 248 gray, and mean lung dose 2 gray under mean software calculations. The outcome technical success achieved in all patients. Outcome for the follow-up of 6 months, no reduction in pneumonitis was seen, and the complete response in 5 patients and partial response in 3 patients according to the MDCS criteria. Here, the first patient with NASH-related CLD with HCCs, here there was a hypervascular lesion in the segment 6, and the follow-up after 3 months, there was a complete resolution of the lesion, that is complete CR. Here the mean absorbed dose was 364 and D95 was 170 grays and lung dose was 0.1 gray. The next patient, he's also a NASH-related CLD with HCC. Here we had like ill-defined hypervascular lesion in the segment 3 of liver that was treated with a streamlined tear, and almost complete CR was attained after 3 months of MRA follow-up. Here the mean absorbed dose was 438 grays, D95 was 180 gray, and lung dose achieved was 4 grays. And the limitations. The study was we have a very small sample size and short follow-up period. To conclude, LSF is clinically negligible in patients with HCC with no vascular invasion or with no dysmorphic vessels. So when we plan for the segmental injections of MA, segmental injections MA can be eliminated. Our initial experience with the streamlining trade using Y90 resin macrospace without procedural mapping, angiography, and lung shunt estimation demonstrates that it is feasible and safe treatment options for the selected patients with HCCs. So most of the evidence available is within the Milan's criteria. Our series highlight the fact that it can be done safely in larger tumor as well with the UCS of extended Milan's. Thank you.
So what is meant by mean absorbed dose? And if you're using the MIM software?
MIM software, sir.
So possibly you must be evaluating the dose given post-procedure also?
Sir. Post-procedure also.
So mean absorbed dose is, you are telling what has gone in the tumor along with the adjacent normal parenchyma in the perfused area?
In the perfused area, sir.
And
so we are taking the average of, because the tumor, most of the tumors were heterogeneous, so mean absorbed dose within the tumor as well as in the adjacent perfused areas.
So it must be giving the tumor absorbed dose also?
Tumor absorbed dose. It is basically mean tumor absorbed dose.
Mean tumor absorbed dose. Okay. So it means those patients who have no vascular invasion, dysmorphic vessels. So basically, there are some tumors possibly which are bigger than suggested criteria of streamline, that is small tumors if you are doing segmentomy, but you have done in few cases which are beyond segmentomy. So are there like what is the vessel mean vessels catheterization and infusions? Are they most of the cases are single vessel infusion, or there were cases where there are 2 infusions?
So most of the patients who are single vessel infusion, single target artery, and very few cases are like multiple, 1 or 2.
Thank you.
Thank you, Dr. Mahendra. Dr. Apurva. OP18.
So my topic is vesical artery embolization for BK virus hemorrhagic cystitis post haploidentical hematopoietic stem cell transplantation. In hematopoietic stem cell transplant recipients, BK virus-related hemorrhagic cystitis is a very well-known complication, and it usually occurs about 30 to 90 days post-transplant, and it leads to gross hematuria, prolonging hospital stay and transfusion dependence. BK virus causes urothelial inflammation and epithelial damage, causing diffuse mucosal ooze. And usually the conservative methods like bladder irrigation, antivirals, intravesical agents usually fail, and that's when vesicular artery embolization comes to rescue. It helps in achieving rapid hemorrhagic control, is minimally invasive, and is bladder preserving, and it avoids high-risk surgery in patients who are immunocompromised especially. Anatomical identification is the prime thing that is important. The vesical arteries are superior and inferior vesical arteries. Superior vesical artery supplies the superior part, including the dome and the superior surface, and the inferior one separate the bladder, but also sometimes supply the prostate and the seminal vesicles. Frequently, there's a common trunk, which is a superior and inferior vesical artery from where it arises, and basically the vesical artery arises from the proximal part of the anterior division of the internal iliac artery. This is a line diagram showing the right side internal iliac artery. This is the superior gluteal artery goes posteriorly, and then this is the anterior division. Usually the first branch that arises is the vesical artery. This is the diagram from the left side, the internal iliac artery, the superior gluteal artery goes, and then there is this is the anterior division of the internal iliac artery. This is the superior vesical artery. As I said, there can be a common trunk, the superior vesicle and the inferior vesicle. What we have to take care is that sometimes the prostatic artery is arising from the proximal part of the superior vesical artery, which is a frequent occurrence. And in such cases, we have to ensure that we are going distal to this artery. So this is the angiographic image. Again, you can see here, this is the internal iliac artery, the posterior division and the anterior division. This is the superior vesical artery. As I said that sometimes there are common stump. This is the angiogram where we got a common stump, that there was a common vesical artery which was giving rise to superior vesical artery as well as the inferior vesical artery. The critical step, as I said, is the identification. Dyna-CT is the thing which is the go-to, where which would make by which we can actually ensure that we are in the right place. If it's not available, then blush and engorgement and tortuosity around the Foley's bulb. And what we do is we instill contrast in the urinary bladder to confirm that we are in the vesical artery. So in this image, you can see this is the Foley's bulb. We instill contrast in the urinary bladder. And then when we did an angiogram, we could clearly see that we are in the vesical artery. So coming to the study per se, in a span of 5 years, 15 patients underwent vesical artery embolization, age range being from 5 years to 45 years. Our youngest patient was 5 years of age, thus saying that age is not a limitation in this study. There were 9 males and 6 females. All the patients had undergone an haploidentical transplant, and cyclophosphamide had been used for preconditioning for immunosuppression. In all patients, the BK virus load was more than 10⁻⁷, that is a very high load, and all these patients also had thrombocytopenia and had failed conservative management. The average time after presentation was 41 days after transplant. Coming to the technique per se, transfemoral access was taken to cannulate the contralateral artery. We used a 5 French Cobra, and then for the ipsilateral, we used a SIM1. In both the cases, we could see the blush. In all the cases, we could see the blush, and superior vesical arteries were identified as using the same technique as I showed earlier in the images. Deep cannulation of bilateral vesical arteries was done, and embolization was done using 300 to 500 microns PVA particles followed by gel foam. Bilateral superior vesical arteries were cannulated in all cases. In 2 cases, we had a common trunk, and thus embolization was done for both the superior as well as the inferior vesical artery. Endpoint was considered as disappearance of vascular blush with marked slowing of the antegrade flow, and continuous bladder irrigation continued 48 hours post-procedure. In 1 patient, we did only unilateral embolization because it was a pediatric patient, and we had this fear of bladder necrosis in a pediatric patient, so we did a unilateral embolization. Again, these are the images. Pre-procedure, there was a blush, and then this is the post-procedure image. Same. Ultrasound images also, so this was the pre-procedure where the bladder was full of clots with a Foley's bulb in situ. This is an ultrasound 3 days post-procedure where there are no more clots, even though there is persistent bladder thickening, but when we put Doppler in this thickening, there is minimal blood flow or minimal color uptake. Technical success was achieved in 100% of the patient, and 11 patients showed complete response, that is 80%, which meant that post-procedure for consecutively 2 days, there was no macroscopic hematuria. Partial response we got in 4 patients, that is 20%, and partial response was defined as a decrease in the intensity of hematuria, but it not completely subsided. There was still some persistent macroscopic hematuria. Hematuria resolved within a median of 3 days post-procedure. None of these patients further required any sort of transfusion, and median hospital day was 5 days. 2 of our patients did have transient pelvic pain post-procedure, but there was no other complication like bladder necrosis, rebleeding, or any sort of bladder contracture. Amongst the 4 patients that we had partial response, 1 patient was a pediatric patient, as I showed, where we did unilateral embolization, but in that patient also, after alum wash, there was a complete response. Again, another adult patient where there was a complete response post-alum wash. In another patient where we had actually embolized the common trunk, the superior as well as the inferior, but he continued to bleed. We had to do a right internal iliac artery coiling, the anterior division. And in patient 4, there was a Grad failure with persistent pancytopenia. This patient continued to have macroscopic hematuria despite clinical success and technical success. So take-home message is that selective vesical artery embolization is effective and a bladder-preserving treatment option in patients who are not responding to medical management, and it can lead to marked improvement outcomes in BK virus hemorrhagic cystitis post-stem cell transplant. We achieved durable hemostasis in 80% of patients as a standalone procedure, and nearly all patients with adjunct conservative measures. It reduced the transfusion need, prevented the need of major surgeries and morbidity, decreased the healthcare burden which is associated with BK virus cystitis. Thank you.
So, your second slide possibly said that the medical treatment fails most
that
of the time.
high
Yes,
vapor
yes. So do you
sleep that
recommend
limits for the lateral
being
energy
is as
transfer.
a secondary method, it should come as a
So
possible
while
primary
our
method
study is
towards
limited
significantly
by
reducing
its
Sir, where
retrospective
the
design,
severity is
sample
relatively
size,
less. In
the
such
lack of
cases, we
subgroup
can still resort to
analysis
conservative
across
methods like bladder irrigation. But there are other methods which are described in the literature like intravascular, cidofovir, and all of that. I think vesical artery embolization is way superior to all those methods in terms of length of is relatively less. In such cases, we can still resort to conservative methods like bladder irrigation. The cost, but there are other methods which are described in the literature like intravascular, cidofovir, and all of that. Vesical artery embolization is way superior to all those methods in terms of length of the treatment for which the chemotherapy has to be given, and the cost. No, sir, there is no cost. So basically, for BK virus per se, there is only one pediatric study which has been reported earlier in the literature of 26 patients. There is no rebleeding, and there is a study of unilateral versus bilateral where there is a significant difference. 60%. No, sir, there is no. So basically, for BK virus per se, there is only one pediatric study which has been bilateral. So we have chosen to do bilateral in all cases. There is no rebleeding, and there is a study of unilateral versus bilateral where there is a significant difference. 60%. Curative after unilateral and 92% after bilateral. So we have chosen to do bilateral in all cases.
Thank you, Dr. Apurva. Next, we have a presentation from Dr. Anurag, OP63.
No, but I need the mouse. Which one? No, you will have last one. Directly? Yeah. No, but I need the mouse. No, you will have one.
oncology session. Let's now switch gears to a more benign topic. Oncology session, everyone. The topic of switch gears to a more benign topic. Percutaneous management of pediatric post-liver transplant biliary strictures. And we'll be looking at long-term post-liver transplant biliary strictures. And we'll be after pediatric liver transplantation, biliary strictures can be seen in up to one-third of transplantation. Biliary strictures can be seen in up to one-third of patients, and biliary strictures can contribute. Various management strategies exist, and various management strategy allows if anatomy allows available, ERCP expertise is available. ERCP should be considered as the initial modality. In the setting of pediatric bilioenteric anastomosis and ERCP failures, is usually the go-to strategy. Sometimes we have to resort to non-anatomical biliary internalizations like hepatogastrostomies and sharp recanalizations, and surgery is of course the last resort. We aim to analyze the long-term outcomes associated with biliary management strategy via PTBD. It was a single institution retrospective analysis of 24 pediatric LT patients between 2011 to 2020 who were diagnosed with biliary strictures. The primary outcome was an optimal biliary outcome after 5 years of intervention, defined as graft survival, with stricture resolutions without recurrence and not requiring surgery. After a diagnosis established on ultrasound, MRCP in the setting of strong clinical suspicion, we decided whether to do PTBD or ERCP first. The PTBD was being planned, the ducts were punctured, internalized, and then a stitchoplasty was carried out, followed by internal drainage or rendezvous stenting. The patients were then put to a 3-monthly catheter exchange program for 12 months, and at the end of 13th month, a cholangiogram was done, followed by tube removal if deemed fit. Strictures were anastomotic at the site of anastomotic healing caused by and first year was the most common time these were encountered and associated by leaks in most of the cases. Non-anastomotic strictures were 5 millimeters away from the anastomosis and multiple longer and risk factors including immunological like cholangitis, rejection, and vascular causes associated like hepatic artery thrombosis. This was an example of acute on chronic rejection with a non-anastomotic stricture. So out of 410 pediatric LTs in this decade, biliary strictures were seen in 24 patients, and out of these 17 underwent a PTBD. 13 as first line for and 4 patients as a bailout strategy after failed ERCP attempts. A median follow-up of 10 years was there. Out of our 17 patients, 3 had to be from the long-term analysis, as 2 were lost to follow-up, and one PTBD was not internalized. And out of these 14, 12 completed the catheter exchange program. One patient died of sepsis once he traveled back to his country in Africa. Another patient required surgery after 3 months of initiating treatment because of chronic rejection. So out of these 12 patients, 75% or 9 patients had an optimal biliary outcome after 5 years. Let's look at the 3 unfavorable outcomes. One patient had a recurrent anastomotic stricture which required a repeat. Ultimately, this patient had non-anastomotic strictures, and another patient developed biliopathy later on in the background of PVT and required a repeat PTBD. Another patient required a retransplant because of recurrent sclerosing cholangitis and eventually succumbed after the repeat transplant. So looking at the adverse outcomes, was 1 out of 12 and was managed with the repeat PTBD. Disease progression was seen in 4 out of 14 patients due to non-anastomotic strictures, as I just described. 10 patients had early strictures within 3 months. 60%. That is 60%. A lot of them were associated with bile leaks. Looking at the survival rates, patient survival rate was 75.7%, with 2 mortalities as previously described. And the graft survival rate was 78.6%. Another graft loss was due to rejection, and this patient did well after a retransplant. The PTBD catheter duration was kept at 13 months. Some patients required prolonged catheters. Most of them were related to vascular complications like hepatic artery thrombosis or PVT-related portal biliopathy. Sometimes when we used a non-anatomic internalization, we would like to keep the catheters longer. Out of the vascular complications, 4 patients had them. 2 had hepatic artery thrombosis, out of which one developed an asthmatic stricture, which was managed with an additional PTBD. Two patients had PVT, out of which one had portabiliopathy, again managed with PTBD. So predictors of poor outcomes were actually related to background pathology and not related per se, non-asthmatic strictures developing in the setting of an autoimmune chronic rejection, sometimes associated with sepsis, and vascular complications created this scenario. Sometimes we resort to non-anatomical internalizations. For example, this patient where the segment 2 catheter could not be internalized despite various attempts. So we attempted to do a sharp recanalization from segment 2 to the segment 2 duct. In this fashion, CT was done, and then segment 2 had a Dormia basket, segment 3 had a central puncture needle. How we punctured, and once internalization happened, use the retrievable covered metallic sems to widen out these non-anatomical tracts, and then converted to a stenting and then catheter exchange program. Finally, everything removed after 18 months. Another one where could not internalize the right just winding up. We planned a hepatostomy via percutaneous access, and this is how it was done. PTBD is an effective rescue in these patients, and these favorable long-term outcomes have been seen. Successful cholangioplasty and internal drainage can prevent the need for re-exploration. Thank you.
So how many cases there were total
17 PTBD with PTBD.
How many cases were duct to duct, and how much were HJ?
So duct to duct for 4, sir. Out of these patients, these were actually failed ERCP. After they did anterior or posterior, and one was left.
4 were duct to duct.
Yeah.
So have you tried to evaluate that whether those unsuccessful cases whether they were any correlation?
No, sir. I know, sir. I did all the numbers. First of all, the numbers are small. Secondly, the thing is that the ones with failed ERCP, 2 out of those we had to do non-anatomical. So anyhow these will take longer. The catheter duration will be longer. However, both of them have done well. And the poor outcomes are only associated also in other studies with the background pathology, which is rejection, leading to non-anastomotic strictures. For anastomotic stricture, the recurrence rates are low, and the success rates are to the tune of 80% as in our study.
Possibly non-anatomical corrections which were made. 3 patients. 2 out of these pediatrics. You can give the idea how much is that you have follow-up of these.
So 5 years. All of these are more than 5 years. One is 5, another one is I think 9 years now.
4 years too.
Yeah. Yes, sir.
What was the age of these?
One of them was 8 years of age.
No, total 17 patients.
I haven't included.
They are mostly small. Managing these medications with internal drain for a year is really tough. Have you ever thought of considering primarily replacing a retrievable biliary stent in these cases, especially pediatric?
We have started moving to biodegradable stents for this, but retrievable covered stents we did only for these two which were non-anatomical. But like you rightly said, it's very difficult to manage catheters, and so we are moving to biodegradable stents. We have one planned for the patient plan in our retrievable stents as well. These patients are in the recent timeline, so I haven't included those. It was a long-term study. Thank you, sir.
Thank you all. We are done with the session. Thank you. Dr. Anurag, your pen drive. Dr. Anurag, pen. I think you should.
lunch, so I'm thinking. What? How are we doing? Maxim Mitkin, I'm University of Pennsylvania and also numerous Children's Hospital. So we have a lot of time. We have 1.5 hours. And it's kind of basic. So I go literally slowly through, try to slowly to go through every aspect of the simple stuff. This is what we'll talk about: physiology, imaging, thoracic duct embolization, interstitial lymphatic embolization, chylothorax, cholelithitis, liver lymphuria. And tomorrow I will talk about much more interesting. I have a half an hour, talk about kind of future, what in the pipeline, what we're doing already, and it's all around decompression of the lymphatic system, because at the end of the road, what's important is to decompress the lymphatic system, because that's 90% of the problems. So of course, this is Dr. Kopp loop micropuncture set. He started developing the first one, lymphatic interventions, thoracic duct, and this is my graduation. I look a little bit younger. It's 25 years ago. 25 years ago. It's University of Pennsylvania does very fancy graduation party, like black tie, cigars and dancing and stuff like that at Four Seasons. So this is my graduation thing. So a few words I'll talk about the lymphatic system. So the idea of lymphatic system is take every fluid from the tissues and deliver it back to venous circulation. And of course, the process that moving fluid from the capillary into the tissue governed by Starling equation. Starling actually didn't write it. It's actually, the person who wrote it is actually somebody from University of Pennsylvania, Eugene Lansley. He just figured out and described it, right? But it's always balanced between oncotic and hydrostatic pressures inside the tissues and inside the vasculature. So, and what's super important to understand, and that's why it's our future, is that the lymphatic system is the only one that removes fluid from the tissues. So every time you have something that edema or collection of a fluid, actually it is a lymphatic system responsible. Heart failure, any ascites, is pretty much 90% of the lymphatic system. Another important thing to understand, that most of you already know that most of the lymphatic system actually deep inside your body. It's a liver, it's intestine, right? They generate approximately 90–80% of the flow in the thoracic duct. And flow in this system fluctuates significantly. If you have liver congestion, it will be enormous amount of flow coming from the liver. If you eat heavy food, it will be enormous amount of fluid coming from the intestine. So this is one of the oldest book from 70s, like huge book about lymphatics, because lymphatics in old days was very popular. So the lymphatic system, lymphatic fluid from different organs different, and that's super important to understand. Why? Because that's, by doing analysis of a fluid, we can figure out where's the fluid coming from. And we, at this moment, right now, we're using primarily three indication. It's triglycerides, of course, it's chyle, albumin, super important. Why? Because albumin, very predetermined. Next slide I will show you. The concentration of the albumin in different limbs is different. And of course, cell count is differential. So usually in the blood it's 20% lymphocytes. In lymph it's 60 to 90, or you go by how much in the blood. If you have lymphopenic patient, you can say, oh, 3% lymphocytes is nothing, right? But then you look at the numbers in the blood, and it will be like 0.5%. Okay, that's actually lymphatic fluid. So it's relatively. We come in with paper about that. So this is albumin, again, from the same book. And the idea here is in thoracic duct, the highest concentration of albumin in the tissue, in the outside blood, is in the liver lymph. Why? Because there's a huge holes in the sinusoid, and albumin comes freely. Of course, gastrointestinal, 60%, and thoracic duct, something in between. Whereas lymph and cerebral trunk, sorry, that's a mistake. It's supposed to be 30. I'm not sure why. Yeah, that's my fault. It's supposed to be 30. It's not 60. So that's when every patient comes to us, he goes through this kind of analysis. Okay, what we have triglycerides, what we have albumin. Of course, triglycerides high, albumin high. Then we have chyle. If it's triglycerides low, albumin low, it will be soft tissue. And of course, liver lymph triglycerides are low, and albumin is high. It's almost 100%. It's not 100%. Sometimes we have confusion. And of course, we are working on developing new biomarkers. We're sending this fluid for omics, and at some point, maybe 2-3 years from now, we'll have an exact test for every lymphatic fluid. And by using this analysis, we kind of can classify where's the lymph coming from. Most of the time in chest, it will be chylothorax. Sometimes it's a liver lymphoria in chest can happen as well. Pelvis, groins, most of the time it is soft tissue. Abdomen depends where. Sometimes in the pelvis, most of the time in pelvis it will be soft tissue, a little bit higher will be chyle, and of course you have a disruption of the liver lymphatics, it will be a liver lymphoria. So this is short synopsis of all lymphatic pathology. Of course it's a simplification. Traumatic, not traumatic, right? For traumatic, we're talking about two things: transection, just cut the lymphatic vessels and they're leaking, but also obstruction. Surprisingly, we started to see more and more people that have obstruction of the lymphatic system, primarily thoracic duct, because of surgery. And when the moment you clean it up, the lymphatic system, and right now there's a new thing we're doing, we're actually using TPA to open the lymphatic vessels. It works amazingly, amazingly well. So you can cure cholelithitis, chylothorax, and also lymphedema. Of course, radiation, there is not that much to do at this moment. We're still experimenting with TPA for radiation. We don't know yet. In non-traumatic, it's all starts with lymphatic obstruction. It's all about lymphatic obstruction that can cause either lymphatic leaks or organ edema. Abdominal edema, retroperitoneal edema, and so on and so on. We'll talk about that a little bit more tomorrow. So, of course, everything started with Scope when he actually figured out how to catheterize thoracic duct, and suddenly it's given a stimulus to all of us to do something, because we actually can see the lymphatic system and actually can do something with that. And that's how us and others came with intranodal or interstitial lymphangiography. It's more common name, like it's intranodal lymphangiography, but it's a little bit confusion right now because different people are using different names. So, of course, intranodal lymphangiography is fluoroscopy, MR lymphangiography, and gadolinium and CT lymphangiography, water-soluble contrast. If you inject mesenteric lymph nodes, it will be mesenteric lymphangiography and liver lymphangiography. And of course, you can do a neck as well. So this is how it looks like. It's very, very simple. We, of course, using right now this hook needle that have a tiny hook that grab the lymph node. And it works very well. I'll tell you how and when. When you position your tip of the needle, actually, we originally said in the cortex, right, or transition. No, you have to go to the hilum. And when you do this, access the lymph node, you actually feel this resistance. And the moment you go to this resistant point, you know you are perfectly there. But you have to be very careful, because if you pass the resistant point, you just pass the hilum, and it wouldn't be good. Of course, watch for lymphovenous connection, because you don't want to inject lapidol into veins. And how to deal with that, you can reposition in the same lymph node, or sometimes access the different lymph node, or sometimes there is no. Some people have totally obstructed, and any lymph nodes you access, they will be leaking. So this is how it looks like on ultrasound. So you see this white stuff here. Needle comes, touches the cortex. We look left, right, left, medial, lateral. Okay, we're in the center, and then I advance a little bit into this white stuff, right, and deploy the hook. And of course, here is the lymphangiography. And this is a hook needle. Again, it's become indisposable in my practice, but people like it. Right now, there's almost 70 hospitals in the country using that. A lot of time, you actually, instead of injecting the lapidol by hand, we attach it to the syringes and inject.
Hi, this is our preparation for the intranodal lymphangiography. At this moment, we use it with this needle. It's a spinal 25 gauge needle connected to this connector. This is very important because during the lymphangiography, we would like to switch different contrast. So this allowed us to switch the contrast without moving the needle. Then we have 3 syringes, and I like to color code that: yellow for the oil-based contrast, lapidol; blue for water-soluble contrast; and white for saline, and here we have Lapidol, contrast, saline, and the fourth cap is actually for the methylene blue, because when we're going to do procedure and we surgeons open the neck, one of the ways to identify the thoracic duct is by us injecting this saline. So here we go. We take a little Lapidol right now into a yellow syringe, connect it to the needle, and flush it, of course, and we'll go to do the lymphangiography.
So how do we speed up, the most important thing, how do you speed up the propagation of contrast? There's four techniques, and actually number 5 came in. First, lymphatic compression on calves. We did study, we showed it's better. Saline flush. So remember we had this syringe with water, saline. So I used it a lot. I actually use saline as a contrast, negative contrast Lapidol. So you feel the lymph node and Lapidol stuck there. You access the lymph node with the saline and flush it out. And if you position well, you can again add more contrast. So this is the number 3, axis of upstream pelvic and abdominal lymph node. And Ajit Yadav actually came with the idea of hitting Lapidol. We use it. It has to be official study to show it's working, but we definitely use it. This is the cuffs, of course. It's what we use. We actually use the alternative compression device for DVT, and it's worked for us. It's cheap. So this is how, let's say, lymphatic Lapidol fill the lymphatic system, and everything kind of stuck here, and nothing goes. What we're going to do, inject saline and propagate it further. Just be prepared if you do it under local under moderate sedation. Saline is very painful, so I will inject a little bit lidocaine before. So this is the same thing here. You can see that we flush the Lapidol with the saline. So here nothing goes forward. Everything stops. So what we can do, we can access this lymph node under fluoroscopy, position it nicely, and then inject saline. And look at that. We actually can flush Lapidol all the way up. You can see it well, right? Do you think we can dim the lights here somehow? So you can flush Lapidol, and after we flush Lapidol, in the perfect position. Okay, let's inject Rapidol or contrast, and this is next lymph node will be here apophysified, and you can access that. This technique I use every case. Because of doing all these combinations, we actually can reduce the time from lymph node injection until we get the thoracic duct for like 10-15 minutes. I don't have any patients. And of course, for this retroperitoneal pelvic lymph nodes, you can use hook needle is very valuable because it stays there and just keep injecting and injecting. Here's a new technique using the hook needle. We actually figure out that we can do regular contrast. If you inject very, very hard, I'm not sure how much you see that. Do you see the thoracic duct? This is like 2 minutes after inject lymph node. Cisterna calli, sorry, here. Oh, you don't see my, actually you don't see my, oh, hold on, you don't see my, okay, here we go. So you see here? This is actually thoracic duct, cisterna calli. Interesting. I actually could not. I probably have to. I can do it there. Yeah. So this is cisterna calli. So, and then what you do? So again, you can see it here, very faintly. Sure. That's just my imagination. Of course, I see it much better. So you can see it. So what's the beauty of this technique? First, it's very short, right? You inject, pressurize, inject contrast, of course, 300, 370, and inject as hard as you can. You can access the upper lymph node and inject more. And then this contrast fills the whole cisterna calli. Because when you use Lapidol and the flow is very fast, you only see like bubbles going through. Here you can see the whole cisterna calli. It's only for 30-40 seconds, but it's enough time for you to get access to that. We did 15 cases like that, and it works magic. And actually, there's even more other advantages that I just don't have to talk, don't have time to talk today about. So next, oh, here we go. Sorry. So of course, this is just diagram where you can inject the lymph nodes. Anywhere you can have them. Mesenteric, definitely. Intranodal neck lymph nodes, axial lymph nodes, if you can find. Popliteal, very, very hard to find. And of course, liver, right? Liver lymphangiography. So also, this is a diagram to show you the relationship. So you have a chyle that comes here and hooked up to the retroperitoneal lymphatics and continues in cisterna calis. So this is where all the chylous pathway going through, right? So that's a reason, if you, and I will talk about that later, if you have a rupture or something here, you do intranodal lymphangiography, you're not going to see any leak. Intranodal lymphangiography will be absolutely normal. Sometimes liver lymphatics hooked up somewhere here to the mesenteric. So you can do from liver lymphatics show mesenteric lymphatics. It's possible. So that's the reason when we have difficult cases, such as callus ascites, not traumatic, we inject everywhere. And something communicate with something, but primarily mesenteric lymphatics for callus ascites. So again, another schema of what different lymphatic imaging we have. We right now have more lymphatic images. I will show it tomorrow. Something you can actually drink and actually can absorb in your intestine and see thoracic duct. It's called PET scanning technique, 18 FTHA, but also got a lot of money for government, developed the same thing for CT and MRI. And we're already working very hard. Actually, the first rat will be injected when they wake up tomorrow, wake up on Thursday in the US. So with the first experiment was the first things will be done tomorrow. So this is MRI. This is always show the same slide because they're kind of nice. On the left, and by the way, interrupt me, ask question in the middle. If something not clear, I want just, we have plenty of time. So you can see thoracic duct kind of normal on the left side. Obviously, we missed the injection on the here. This is CT lymphangiography, one of our first cases. I don't use it, CT lymphangiography, because MRI already well established, number one. Number two, we get feeling that sometimes a CT lymphangiography is not as precise as MRI. Contrast doesn't go to the periphery, but a lot of people in the world using CT lymphangiography and treating based on that. So, and of course, this is abnormal. You can see here's thoracic duct have this flow into the mediastinum. This is a patient with plastic bronchitis, and here's clearly something abnormal. There's two things going on here. Number one, there's a lot of lymphatic production. That's the reason why it's such a dilated thoracic duct. Some people have it. This is one of the pathophysiological mechanisms. Some people generate enormous amount of lymph out of nowhere. Definitely 100% Noonan and most of it down. Costello syndrome have a very, very brisk lymphatic flow. And that's one of the reasons why Noonan patients has so much lymphatic problems, right? Because imagine yourself, you have a huge river going, and you have some kind of blockage accidentally happen, and then you have a leaks, collaterals, protein losing enteropathy, edema, chyluria, scrotal lymphoria, chylothorax, you name it, because there is enormous amount of lymphatic flow in the system of Noonan patients. So MRI, generally we have two techniques, T2 imaging and contrast injection. And of course, we inject contrast into the growing lymph nodes in these cases. And both these techniques are kind of complementary. So we do injection through the injector, and this is our kind of poor man setup to do that. And this is how it looks like on a real patient. This is our injection rate. We never optimize that. We don't know if it's right or not. We just started doing it. It's kind of working, so let's go with it. We probably at some point need to optimize it better. Why T2 imaging is important? Two reasons. You can see fluids, you can see edema, you can see masses that you don't see with contrast injection, because sometimes the mass is outside the pathway of the contrast. This is an example, of course, masses on T2 imaging and of this pleural effusion. This is another example of mediastinal masses. You can see tortuous thoracic duct that tell you that there's something going on with lymphatic system, some type of obstruction. You can actually see collaterals develop. Again, sign of a lymphatic obstruction, and for rare diseases, you go to the bone lesions. But here's an example of why we use it. This is a lady that developed horrible abdominal pain, and it's, by the way, we started to see more and more patients. We didn't advertise it yet because we're afraid that all country come to us if we say, oh, we can treat abdominal pain, here we go. So two of my daughters have candidates for my procedures, I think. So it's such a common disease. So this is our first ever we done. So we did T2 imaging, and we can see here, and during that time we actually didn't realize it, this is actually very dilated thoracic duct, and you can clearly see that. But on imaging, you don't see it at all. Why? Oh, because, and this is lymphangiography, you can see that slowly, contrast propagate until we see the obstruction of a thoracic duct. And that's the reason we don't see it, because the contrast, that when we inject groins, it just doesn't go there. And of course, we see this nice clot. And during the time, we didn't know what to do about this clot. Right now, we do it a bit different. I pushed it somehow with my wire, because I didn't expect to see it. Like it was 7, 8 years ago. So, and since then, she's asymptomatic 7 years. She doesn't have any abdominal pain. Before that, she was going to emergency room twice a week, twice a month. And you can see here, this is your clot and thoracic duct. After opening totally, and ask you to cough just to clean it up more, and it's working very well. So this is our actually first time I ever saw clot in lymphatic system, and right now we see it more and more. Liver lymphangiography. So when we do liver lymphangiography, you actually your target is white stuff around portal vein. What is white stuff? It's dilated lymphatics. And so every time you read, or your colleagues read CT or ultrasound, MRI, and say, oh, there's a periportal thickening. It's actually dilation of lymphatics. The same goes with gallbladder. Right? If I don't have this images here, but a lot of time you do liver lymphangiography, you actually can feel with your contrast from the peripheral lymphatics gallbladder. So every time you have, edema, like heart failure and gallbladder thickening, that's dilation of the liver lymphatics, gallbladder lymphatics. So this is one of our cases. So you can see here, we put a needle inside, and you clearly can see leakage of the contrast into the duodenum. Okay? So when do we use liver lymphangiography? Liver lymphoria. It could be traumatic and not traumatic. We actually started to see patients, we only have 5, with ascites in horrible heart failure, in okay heart failure. So patient actually normal ejection fraction with some a little bit elevated, some valve replacement, horrible ascites. We do liver lymphangiography, and we actually can block lymphatics, and they're cured. We just submitted a paper about that. Protein-losing enteropathy, of course, that's how we started our journey with protein-losing enteropathy. We still use it. Callus ascites, for sure, it's another entry point. And in some cases, there's a plastic bronchitis. We published a few papers about that, where you actually do liver lymphangiography and see lymphatics shooting into the mediastinum. And I'm absolutely guaranteed there's some patient that will have pleural effusion because of the communication between liver lymphatics from the falciform ligament into the mediastinum. Because we saw plastic bronchitis, we have almost 10 or 11 cases, primarily children. We have 2 adults right now. So, of course, when we develop this new liver lymphatic imaging agent, where you inject IV, like a HIDA, lymphatic HIDA, right? You inject IV, then we'll figure out. Okay? Mesenteric lymphangiography is super important. Been done for many, many years by a lot of people in OR, and kind of obscure papers were out there, but eventually Sabian Hoor and his team performed this intraoperative mesenteric lymphangiography, and then we started to do percutaneous one. And we published paper about that, and not referenced with Sabian approximately 6 months ago, and we designed different classification of mesenteric. Useful, definitely useful technique, not for everybody, but definitely protein-losing enteropathy and callus ascites. So here you can see we inject lymph node percutaneously, and here you can see the contrast leaking into the duodenum. Of course, this is a patient of protein-losing enteropathy. For mesenteric lymphangiography, these needles are must, because it's almost impossible to put needle without sliding out in a second, so it's actually a lifesaver for us, for sure. So where we've been before we developed all this lymphatic imaging? That's what we've been. Like, that's our diseases. Lymphedema, of course, everybody knows lymphedema. Lymphatic leaks, Kyle, right? Lymphatic malformation. Pulmonary lymphatic disorders. Why? Because biopsy. Somebody biopsy lymphatic tissue lung and see the lymphatic tissue here as pulmonary. And protein-losing enteropathy for the same reason. So right now, that's where we're standing. We already started to discover more and more diseases, understood pathophysiology of a lot of diseases. Kyle-Urey, it was a mystery disease for everybody. And right now, we know it quite well. So I will try to apparently, there's a lot of Kyle-Urey patients in India, right? So tomorrow I'll try and put a few slides about how to treat Kyle-Urey. It's actually not bug-related, not bug, parasite related, because I actually never done one. We always have ones that spontaneous because of obstruction of the thoracic duct. So maybe it's totally different. I don't have any experience with that. Of course, all pulmonary lymphatic disorders, Kyle's ascites, we understand much better what's going on. Protein-losing enteropathy, genital lymphoria. This is super important one, chronic acute abdominal pain. We published paper in radiology, but we actually never advertised that, and it's very, very careful about that because we didn't have a drink. So right now, of course, this patient was chronic and acute abdominal pain. I'll talk about that tomorrow. They have obstruction of the thoracic duct. So but it's very hard to understand who is obstructed. So the moment we'll have this drink where it absorbs clinically for everybody, so then we'll do clinical trial with imaging of the lymphatic system. This is a big one right now for me. Become abdominal and lower extremity edema. We started to see more and more patients. We figure out different ways to decompress them. I will talk about tomorrow. And liver lymphoria ascites and many more diseases. So any question about imaging? So we will move to procedure. So there's a three group of the procedures. Classical thoracic duct embolization, interstitial lymphatic embolization when we inject tissues with glue. And this one, we'll talk about that tomorrow because it's future. We'll all be doing a decompression of thoracic duct in 3-4 years from now. At least I hope so. So thoracic duct embolization, two main indications, calothorax, plastic bronchitis, right? Plastic bronchitis is quite common in the US, but still underdiagnosed condition. Right now we supposed to publish in the radiology, it's already a second review paper. It was 80 plastic bronchitis patients. 100% of this patient came to us after self-referred and after at least 5, 6, 7 years constantly coughing and nobody diagnosed them. So hopefully with our big paper and this we try to advertise, get into the heads of pulmonologists that it's a real condition. And I'm sure there's a lot of patients in India, 1.4 million people, right? Thoracic duct embolization. Start with internal lymphangiography. We talked about that, thoracic duct access and thoracic duct embolization. So, of course, you can go through everything. The only thing I would say, don't go for maybe gallbladder, because I heard some people told me that there was a complication when they rupture gallbladder, but usually gallbladder is not on the way, and I'm kind of careful not to hit it. Pretty much the technique is
so we know approximately where the cisterna cali starts. So what I'm going to do right now, I'm going to mark with hemostat the entry point in the skin. It's approximately 3, 4, 5 centimeters from the where we're supposed to stick the cisterna cali. Depends, of course, how big a patient is. Smaller patient will be less. And we start to advance needle until we hit the spine, because cisterna cali sits on spine. Hopefully we'll penetrate through and through. When we advance the needle, we advance it and hit the spine with BL up, then we rotate the needle this way so the wire can go in the cranial direction. So I've started to slowly pull needle back. Okay, I am to the left of the cisterna cali thoracic duct, so I put my needle, relocate it, and stick it a bit more to the left, rotate it up, and slowly start pulling the needle while advancing the wire. No, here we go. We are lucky today.
So of course you don't see cisterna cali. Why? Because I already saw it, the contrast, the bubbles coming through, right? So I know exactly because I'm perpendicular to that, and the cisterna cali sits between the IVC and aorta, I just boom, going down, right? So because flow is sometimes so fast in the cisterna cali, you could not see that. Why is it so fast? Because when you start doing your lymphangiography, the contrast slowly cripple up and still start to fly because liver and intestine lymphatics kicks in and start to flush everything out. So how do we deal with that? So this is one technique, the double needle. So you put a needle above cisterna cali, compress it kind of thing, and then with second needle, after contrast accumulate, you can advance it. Okay. However, Dr. Keong from Vietnam said, oh, I don't do needle, I inject saline. And here we go. You can see here, I put first needle here and inject 20 cc of saline next to the thoracic duct. So it's a temporary obstruct thoracic duct, and immediately started to see accumulation of the contrast, accumulation of contrast below the needle. And then you can you have a target. So it's easy. It's become easy. And here, again, it's kind of, I'm pushing it a bit away, but eventually you can see I'm slowly start to pull back needle and advance my wire until wire goes through. It's a very useful technique. I use it almost every time because it's just, unless you see like beautiful cisterna cali. And all my fellows right now have one stick cisterna cali. If you put the needle against, close to the thoracic duct and infiltrate like 20-30 cc of saline. It's not a problem at all. So thank you, Dr. Keong. So after you put the catheter, there's some technique how to put the catheter, but for some reasons, during the course we train this technique, you can see here I inject contrast and I don't know why it's not working, but you can see there's the reflux. There's obstruction of the thoracic duct and reflux of the contrast inside the lung parenchyma. This is how it looks in the patient. There is a special needle we developed to access thoracic duct. I am not happy about that needle. The engineers right now are redoing it, totally redoing it, and hopefully will come with a much better needle. Probably, I will, at the end of the month, I'll really try a few examples. You can totally embolize thoracic, 014 wire. So we'll have I use transient wire. It's a problem because it's like 30 centimeters. So we actually came with a new wire for thoracic duct that's very similar to transient. It's just very floppy, short floppy, like 10 centimeters, and it's a good wire. We'll love it. It works amazing well. But it's not even in the US available. I think it will be in 2-3 months. You can do embolization of the thoracic duct totally, or you can do act selectively and embolize this branch. So sometimes you can embolize easy thoracic duct in normal people. You have to be careful embolizing thoracic duct in heart failure kids because they can develop protein-losing enteropathy. We still don't know, but better not to embolize. So we're trying to do more selective, but one of the interesting techniques what they're using is that in order to, when you inject your glue, in order to glue and propagate further, but not reflux in thoracic duct, we actually put a second catheter, and while we're injecting glue, we're actually injecting D5 and pressurizing thoracic duct so glue doesn't reflux into the thoracic duct. So other than that, you do thoracic duct embolization with coils, just 014 or 018 regular coils. Why we need coils? Because the glue interacts completely different with lymph and the blood. And Klaus Pieper from Germany did multiple experiments, shows that polymerization is much slower than in blood. So if you inject glue and continue to pressurize it, it will go and flow into the vein. Why? Because the core of the glucose liquid. So it's like lava, right? You inject and it's continue to break and go and flow. So coils primarily to break, give like something to glue to grab. And this is another glue injection. So this is another important thing. So you see, if I inject too hard, it's actually going through. So what's the technique? Number one, dilution 1:1. Don't do 1, 2, 3, not to 1, 2, 2, 1 to 1, because you have plenty of time. And number 2, when you flush with D5, you flush just a little bit. You literally create distance, separate the saline from the glue. Because if you flush the whole thoracic duct with D5, no glue going to polymerize. It's just, there will be no ions there. So number 1. Number 2, the technique is you inject glue, wait until they hit the coils, then you pull back a little bit, wait another 3-4 seconds, inject contrast. If it's contrast glue, if it continues to flow, wait. If it's not refluxing back, you're pretty much done. You pull back a little bit, inject a bit more, and that's it. Most of the time, you don't need more than half cc of glue to embolize total thoracic duct. Is it safe? Absolutely. We submitted to ISVIR' second paper for long-term follow-up. First paper was 14% complication rate, primarily because of pedal lymphangiography. Because pedal lymphangiography causes people lymphedema. The moment we switch to intranodal, no complication of lower extremity edema, but also no pretty much almost 100%, even 10, 15 years, 10 years, 12 years that we're doing that, 13 years after the embolization is no issues at all. So outcomes of traumatic calothorax are very, very good. So this is a study we published, my partner published it, and it's kind of like funny. So there's two different groups, one with pressure cuffs, the other one with no pressure cuffs. I don't know, he wanted to be original. I don't know why he did it. He didn't ask me. Anyhow, in both cases, our success rate is very, very high, more than 90%. And of course, when you put a pressure cuff and increase the flow of the lymphatic system, your procedure time reduces significant. It's statistically significant reduction. So non-traumatic calothorax. For years, it was super difficult for us to understand until we figure out. And right now, we know everything about it, not almost everything. Like we have 1 or 2 cases recently that we're struggling understanding. But pretty much non-traumatic is very simple. Most of the causes, what we see, idiopathic. Why people develop calothorax? Because they're obstructed of the thoracic duct. Why they're obstructed thoracic duct? We don't know, but it's clearly, it could be surgery, it could be trauma, it could be COVID, it could be out of nowhere. Like wake up one day, suddenly you have calothorax. So what do you have? You have abnormal lymphatic anatomy. You have like, instead of one thoracic duct, your thoracic duct with multiple branches. And you can live your normal life until the thoracic duct clogged. That's where we started, not for calothorax yet. Well, in one case, we started to use TPA to clean up lymphatic system and bring it to the native state. But also you can, most of the time you will see, we actually embolize it. Sometimes lymphoma. Lymphoma can compress lymphatics and cause, again, this reflux and leakage. How we diagnose that? We start with MRI. Of course, always we start with MRI. And we're looking for number 1, ascites. Most of the patients I personally get right now is actually callous ascites present as calothorax. Super important because if you have callous ascites and you embolize thoracic duct, you make things 1,000 times worse. And we saw cases coming to us from other places that people just, or surgeons like, oh yeah, calothorax, let's ligate thoracic duct. No, it was callous ascites. And it's just holes in diaphragm. The other 2 causes, the abnormal flow from thoracic duct to the lung. And the third one, also very important, communication between retroperitoneal and mediastinal lymphatics. Again, if you miss this part and embolize thoracic duct, they make things worse because you redirect your flow directly where the leak is. Again, it's all about obstruction. And actually, callous ascites is also obstruction. I just kind of, didn't include it here most of the time. So again, this is a message, very, very important. Don't embolize thoracic duct in presence of asthmatis. So when you say, oh, this patient doesn't have ascites. Because our first question, calothorax, does the patient have ascites? No, he doesn't have ascites, just a little bit. That's it, that's enough. Literally few drops between the intestinal loops, it could be it. Because the mechanism of sucking fluid from the abdomen is very, very good. So you actually can dry your abdomen. And what you do, in the past we used to inject, like put a needle into peritoneal cavity, inject some nuclear medicine stuff. We stopped doing it. We just sample fluid from both places, right? And if it's similar, it's a callous ascites present as calothorax. It's probably like 78% of the cases I do it right now. And so how do you compare fluids? Can you do triglycerides? Yeah, you can do, but let's say a patient ate today and yesterday he didn't eat and will be a little bit elevated but different. Can you do cell count? Yes, but it will be a little bit different. But albumin will be exactly the same. Nothing changed in albumin. No diet, nothing. It will be exactly the same albumin. So that's the reason we use albumin as one of the main thing, right? And of course, when you do, on this patient, you do MRI, usually you don't see this abnormal lymphatics going anywhere. So this is just an example of the
Videotaping right now. Yep, saw that. Yep. Yep.
Okay. Hope so. I'm sorry, I'm not sure why is it going like that. It was not. So the idea is that you can see holes and Kyle going, and you look at the diaphragm right now from a surgeon perspective, from thoracic surgeon.
Videotaping right.
So, so then abnormal form of thoracic duct, you can see it here. Oh, sorry, it's supposed to be like a joke, but you know, hold on, let me do it. So, I'm not sure it's not working. Anyhow, this is abnormal flow, and it's actually a dog. So dogs actually have a lot of calothorax. We treat a lot of dogs right now. It's my partner moved to that. This is our first dog. We actually have a cat. Cats also with calothorax. We actually have Jeff Geschwin cat with callous ascites. So we have a big business in veterinary medicine, right? So surprisingly, actually, it's a very, very developed field in veterinary medicine. We actually trained first 25 years first to surgeons. And one of them, he is the head of, like, he's Chick Weiss, every SIR he'll come. And somebody will make a joke, oh, you put gastrostomy for your dog. It's like, I'm here, by the way. So Chick Weiss, he has a better suite than you have in New York. It's called Animal Hospital. That's the name, Animal Hospital, something like that. American Medical Hospital. So it's a 7 floors building with a radiation unit, huge radiation in the basement. His IR room has a CT, ultrasound, and endoscopy all built in. Everything comes in, right? So, of course, there's a Kissinger. He's on board, and everybody on board of all these famous New York people with their pets. Anyhow, it works very well. We didn't publish a paper. My partner took over. We did 50, 60 dogs by now, probably. But this is a real patient. Right? And the idea here is, of course, super fast lymphatic flow. This is a normal guy, just from Texas. I remember well. He lives his normal life, no problems. And suddenly he has calothorax. Why? He has, that's many years ago, he always has abnormal lymphatics, enormous lymphatic flow, and something happened. Somehow he blocked his lymphatic system, clot, and right now he's leaking. Okay? And it's the different variation of this lymphatic flow. This is another example, and you can see even when we inject thoracic duct, obviously it's kind of like a fusiform, but at the end of the road, you can see it here leaking inside the mediastinum. Just another example. So this is easier. You go selectively, non-selective, close thoracic duct, no problems at all. Then you have this situation. This is a patient that has a retroperitoneal to mediastinal connections. And this is another one. So you can embolize thoracic duct because flow also comes from the thoracic duct, but you wouldn't cure the problem because the leak is here. So what you do, you put a needle in these masses and inject glue, infiltrate glue, and these people are cured. But most of the time, it's actually very subtle. Look here. It's MRI lymphangiography, and that's what you have. You have just a tiny dot at the pleural surface. That's enough. This is thing will be leaking. This is a patient with lymphoma, and lymphoma causes obstruction of his thoracic duct. You see, I'm injected it, and it looks kind of normal. Nothing comes off thoracic duct, but clearly some collaterals here, right? So what we do in this case, you again infiltrate these masses. This is our goal. This is where we're supposed to get. This is with pleural space, like that, right? So our goal is to embolize this mass here. It's challenging. It could be done. It's challenging sometimes, but 99% of it could be done. And this is at the end of injection. So we kind of close it and he's cured. This is another example of the a lamp patient. And again, look here. This is what you're looking for. It's exactly that. You want to see this pleural perfusion. So this is where helix is, and then when we do lymphangiography, you can see here in injecting glue into these masses, and that's what brings her comfort and cure. So again, if you miss this thoracic retroperitoneal to mesenteric, mesenteroperitoneal to the mediastinal and embolized thoracic duct, we make things 1,000 times worse. That's the reason it's absolutely imperative to do CT lymphangiography, MR lymphangiography before every thorax. So this is our study we published a few years ago. 51 patients. Again, abnormal flow from thoracic duct, from retroperitoneum and callus ascites. Abnormal flow from thoracic duct, we have a 97% resolution, very, very good. And retroperitoneal, 90%. I don't remember why we failed a few cases, but could be successful all 100%. And of course, callus ascites, it's totally different story, and we'll talk about that. Interstitial lymphatic embolization. So we actually accidentally figure out. We thought that if you put a needle into lymph node and inject glue, the needle will glue almost immediately. And accidentally, we injected glue, and it's actually propagated. It's like, oh my God, this is a new technique. And I remember this case very, very well. So we dilute glue a little bit more than for the thoracic duct, 1 to 2, 1 to 3. We started 1 to 6, and then we realized it does not work at all. 1 to 2, 1 to 3, you actually can propagate the glue from lymph node quite far away. And you can use this technique, lymph node, lymphatic masses, of course, liver lymphatic embolization as well. And it gives us crazy amount of options to treat. What do we treat? Callus ascites, for sure. Chylothorax, again, you just saw this example of what we infiltrate lymphatic mass retroperitoneal. Of course, sometimes thoracic duct embolization, you actually can, especially children, can inject from the lymph node all the way into the thoracic duct if you have a small child. I should put a case here, I forgot. You can do caluria, of course, that's main thing, besides the retrograde access and through catheter. Protein-losing enteropathy for sure. Groin lymphoria, the most common. Like when you start lymphatic business, you start with groin lymphoria, super easy. And vaginal scrotal lymphoria is quite rare. But they have like 3-4 cases a year. So this is how it looks, right? So this is patient post-nephrectomy. You see this lymphatic mass, you inject glue, and obviously it's all abnormal lymphatics. Sometimes you don't see leak, you see like abnormal lymphatics. The moment you close them, the things get better. So we'll talk about PLE, caluria. It's kind of maybe for tomorrow, but we'll talk about groin lymphocells. So this is how it works. So this is anatomy, right? So this is anatomy. Those are first lymph nodes that called sentinel lymph nodes. Usually it's one. And I'll talk about, it's very, very important. We'll talk about them in a second. But everything else, the lymphatics coming from lateral, from medial, through the canal, and go all the way up. Okay? So what's the causes of groin or pelvic lymphoria? Pelvic surgery. But most of the time what we see, it's actually kidney transplant, vascular surgery, groin catheterization, primarily by cardiologists, because they deal with heart failure patients and you have enormous lymphatic flow. That's what problem happened. ECMO for sure. And recently we started to see more oncology sentinel lymph node removal, and we'll talk about that. So this is our first case of 1.5 liter leaking from the groin after ECMO, patient post-heart transplant. This is a leak. This is a tiny, tiny thing. And this is so easy to treat. And the other option for this patient, you couldn't do sclerotherapy, it's just hole in the skin. The other option is to do huge surgery of flap. Just to take and put a flap on the no, tamponade, I guess. That's a technique. And this doesn't work all the time. So we get this patient. So the second one is actually kidney transplant. By now we have almost 40 patients with kidney transplant that we figure out very successfully we treated. And you can see here, I inject lapidol from sentinel lymph node, first one, and they actually can propagate the contrast all the way here. And here actually I inject saline, it's D5. And you can see how can I push all the way contrast into the leakage point. And here we inject glue. And most of the time when you do those, it's better to inject glue very, very close to the leak. But unfortunately here there's absolutely no lymph nodes. So we have to inject from here and we do that. So what's the technique? It's a simple procedure, but it took me sweat and many patients to figure out how to do it right. The most important thing is don't play too much with lymph node. If you inject, let's do it now, let's inject a little bit contrast, let's lapidol, let's do that. At some point you will destroy the lymph node and nothing going to go anywhere. So the general rule, put a needle into lymph node. Right now, of course, we have a hooked one, so it's actually better because the needle doesn't slide out. And you inject, most of the time I inject regular contrast. Sometimes I inject few drops of lapidol and flush it with saline and show the leak and follow immediately with D5. D5 and glue. Glue dilution 1 to 2, maybe 1 to 3 in this case because it's too far away. Number one. Number two, when you inject, you are committed to your injection. You just keep injecting. Because if you hesitate for a second and the column of propagation of the glue stops, it's immediately polymerized and you're done. That's okay, you didn't reach your goal, right? So you have to be quite committed to injection. Yeah, so, and that's pretty much a thing. Now, another rule is look different lymph nodes. Of course, if you have a cardiac cuff, usually they cut only one lymphatic vessel. But if you have a kidney transplant, and we see a lot of those again, pretty much twice or 3 times a month by now, because we started to trust it. It took us like, I don't know, 3 years to convince that that's a good thing. Because if you go to the kidney transplant conferences, we will still talk about lymph cell coming from the kidney. It's like, no, this is dissection of the lymphatics. It's like, oh no, I mean, I literally go to some meeting and there was a transplant surgeon talking about kidney lymph causing lymph cells. Like, what is even kidney lymph is? If you tell me what kidney lymph is, Nobel Prize, because it's clearly, it's a very important thing. We don't understand that because it's participating in exchange of the whatever fluid in the kidneys. 100% at some point we will figure out that kidney lymphatics are super important and answer to a lot of kidney diseases, because people in the old days actually catheterized kidney lymphatics and showed that kidney generates the same amount of lymph as urine, right? So anyhow, it's all, in these cases, it's not kidney lymph, it's actually lymph from lymph nodes, pretty much 100%. So there's a lot of literature here about different lymph cells, because Korean people, Korean interventional radiologists contribute crazy to that. And pretty much everybody's success is very, very high. Different classification and so on. But this is our study where we compare embolization and sclerotherapy. And clinical success was kind of similar, 83 versus 65. Obviously 83 is more, but it's not statistically significant. So we didn't say that we are better. But definitely average procedure rate was less for embolization, right? Anyhow, all right, so that's easy. You see lymph node, you put a needle inside, inject glue, no problems. Let's say you have a patient coming after a melanoma surgery where they remove melanoma and remove sentinel lymph node. What is sentinel lymph nodes? It's actually the first lymph node here, right, that you see. So you don't have a lymph node. How are you going to do that? So all days we develop techniques of what's called percutaneous image-guided lymphatic ligation, where I do pedal lymphangiography, inject contrast, and see in percutaneous ligated. But we don't have equipment any longer. So it was actually not our idea. It was, I didn't put a reference. It's somebody from Belgium. They decided to infiltrate the skin pedal here and did CT lymphangiography and see lymphatics with irregular contrast. But I saw this paper, let's do that. And then I said, like, why shouldn't we do the retromalleolar? Because that's where the plastic surgeon inject their contrast. And specifically, this is a spot between hard skin and soft skin. And look what we got. Beautiful, beautiful lymphangiography here, right? And you can trace it quite well. And actually, you can see exactly where the leak happened. And then you can address that. Yeah, in this case, we cauterized from the cavity and and here I injected, put a cutter, inject glue, but there's a different techniques we can do it, including over-injecting cavity with saline, not saline, with alcohol and just filling these lymphatics. But certainly we have a new technique. I keep saying that we submitted another paper to the JVIR this time around with our first 3 cases because they've been super successful, great. And the year I didn't have any cases. And suddenly I have 5 in 2 weeks. And it's like we're still working on that. I think the solution for that, it's not like you can see the leak, but it's not easy to embolize. But anyhow, it's work in progress. But please help me with that. But again, what's the technique? The technique is you take a tuberculin syringe or insulin syringe and inject intradermal, literally infiltrate the subdermis. And that's how you got it. And location, this is a key. This is a right location. So if you inject a little bit higher, you wouldn't get that. So abdominal lymphatic leaks. So again, traumatic, not traumatic. Traumatic easy, not traumatic complicated. Callus, not callus. Callus ascites, of course, callus. Not callus, 2 types, liver lymphorrhea and some soft tissue retroperitoneal. Pretty much lymphocell. Non-traumatic, callus ascites and liver lymphorrhea. This is 2 we have at this moment. Maybe we'll have more in the future. We have actually treated few ascites by opening thoracic duct that were not callus, but it's kind of, we still don't know what to do with that. So again, we go back to the same thing. Types of lymph, we repeat the same thing. The moment you have ascites, you remove the fluid and you analyze that. And hold on, more importantly, when people say, oh, I would like to refer to a patient with callus ascites, it's like, okay, give me numbers. No, I don't know numbers. Like we know for years it's callus ascites. Yeah. Give me numbers. Until with your eyes you will see the numbers, don't trust anybody because it will be big professor in thoracic surgery and at the end of the road, it actually was an intern 5 years ago said it was not callus. So you have to, with your own eyes, see the numbers because people accidentally confused and whatever, everything. So, of course, mesenteric callus leaks and soft tissue. So we already saw this, just another reminder of the same idea. And you also saw that one, so I will skip on this one. So what the definition of callus ascites, or Kyle? We have no idea. We would know probably very soon because we actually collected lymph from the thoracic duct and pleural effusion of 50 patients, and we're analyzing that. And I actually tested a lot of different things there. So it's still under analysis. Probably during the CRC next year, I will present the data. Oh, we actually presented last year at CRC, but it was bad analysis, so I have to pull the paper out because I didn't realize that my statistician didn't do the right job. Triglycerides, most important. Probably more than 300-400. If you have a less than 200, it's probably will be not callus ascites, definitely on regular callus fluid, definitely not on regular diet. The number out there is 110, and everybody stick to this number because it's coming from 1966-7 paper from Mayo Clinic, and it's wrong, obviously, because it's fluctuate with the food. For that reason, we also use albumin. And of course, percentage of lymphocytes. And the most important, if you in doubt, give the patient food and feed them. So, because we very, very common see this pitfall, liver cirrhosis ascites and portal mesenteric ascites, occlusion ascites. So, and if you go in the literature, you will see, oh, there's a lot of paper, liver cirrhosis causes callus ascites. No, it's not callus ascites. It's callosish ascites. So the moment you do TIPS, it goes away. The same thing here. So this is the patient that came to us with callus ascites. We look at the numbers, and he has post-pancreatitis. We realize that he has narrowing of the SMV. And we stent it, and callous ascites goes away. So you have to be very, very careful, especially when people go in with the big numbers, and you look, and probably last year I diagnosed 5 or 6 times the referral to us. People say, oh, we have callous ascites. Show us the images. Oh, this is liver cirrhosis. Oh, we didn't know about that. Oh, yeah, maybe it's liver cirrhosis. Oh, can you do portal imaging? Can you do transjugular liver biopsy and pressures? Very, 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 very common to confuse ascites of liver and callous ascites. Of course, treatment is totally, totally different. So traumatic callous ascites, it's always come from mesenteric lymph nodes, mesenteric, right? Because it's source of a chyle. And here's the confusion. Sometimes when the people dissect retroperitoneal, cut a huge cavity there, right? And cut mesenteric and retroperitoneal, and you do intranodal lymphangiography, and you see a huge leak. Oh, great, I got it. You didn't, because there's another leak coming from mesenteric. Sometimes you do, and I will show you in a second. So again, you saw this diagram where's the lymph coming from intestine and meet the retroperitoneal. And of course, when you inject lymph nodes, right, you bypass huge part of the mesenteric lymphatic system. So this is situation number 1. You have, it's a pretty much lymphocell. Surgeon do pelvic surgery, cut the lymphatics, and there's a leak, right? We diagnose easily, no chyle, and we already saw a few cases. And this is just another case of the kidney thing, and you can see it's leaking into the catheter and so on. Easy. Okay, this is the second situation. The leak happens after mesenteric lymphatics and intestinal, mesenteric and retroperitoneal lymphatics meet. In that case, intranodal lymphangiography show you a real leak, and you actually can treat it successfully. Here's an example. So this is a patient. We clearly saw a leak somewhere at retroperitoneal, but in mesenteric lymphatics hooked up probably here, because the moment we block these lymph nodes or treat it, so callous ascites went away. This is typical situation, callous leak. You do internal lymphangiography, MRI, everything is perfectly normal, callous ascites. Why? Because leak happened here before it hit the lymphatics. What do you do here? The only answer? Mesenteric lymphangiography. You couldn't do anything else. I mean, potentially you could do retrograde access, but it's complicated. Mesenteric is easier. So, and this is an example. You can see this is leak, and this is mesenteric lymph node, and it's leak here. Okay? And then you have a situation number 3 or 4, where you have a leak, big hole here, and leak from mesenteric and nodal. Whereas people confused, because they they actually glue the leak, but we didn't. And this is the guy that already embolized his. We saw a huge leak in the MRI intranodal, but you can see here we do mesenteric lymphangiography, and this is his leak here. So, and of course, there is something abnormal here. Is no thoracic duct. Obviously, it's not right. And the leak here, and after you inject glue, and we glue this leak. So I didn't show his intranodal images. I probably should, but it was clearly a huge leak on MRI in the cavity from the intranodal. And after we embolized, it didn't work. Oh, actually, sorry. In this case, we even did not do, because I was so convinced that you have to access mesenteric lymph nodes first. We just went immediately with mesenteric lymph nodes and just embolized those. So post-surgical liver lymphoria, where do we receive it? Liver transplant, especially children, because the liver is kind of twisted. And surgery for high of the liver, and of course, there's a different topic of spontaneous liver lymphoria. So why people, why not every liver transplant has a liver lymphoria? Because they cut all these lymphatics, because it has to be something else. What is else? Congestion of the liver. It could be elevated pulmonary pressure, central venous pressure. It could be bad anastomosis, especially in small children when they partially resected liver, so they connect veins, hepatic veins not well, so that's a reason. Hepatitis or liver cirrhosis. So this is our actually first case of liver lympharia, 5 liters a day, and of course, how did I didn't come with this idea? Who came with this idea? Cobb. Why? Because when he developed the new needle for liver focal angiography, he decided that he needs to use the 30-gauge needle to get into the non-dilated liver bile ducts. So, and in his paper in AGR, he actually described that 40% of the time he sees lymphatics, and that's because of that I started to do that. It's all come back to Cobb, right? So anyhow, this is our first case. During the time, I didn't know that we actually can inject glue. Here I use Onyx, right? Because I thought glue is going to embolize, but it worked very, very well. And this is another case of pediatric case of newborn post Kasai procedure, leaking 1.5 liter a day. His weight is like 4 weight like 4 kilos. And the second case you will see it post liver transplant. So here we go. We do very easy to do liver lymphangiography because liver lymphatic very dilated. Why? He has a horrible pulmonary hypertension, very elevated central venous pressure, and you can see leak here. You inject glue, the kid is cured. And this is another case of this insanity of the liver transplant, and you can see clearly the leak here. Why is it happening here? Because probably anastomosis is not great. Non-traumatic callus ascites, most difficult condition to treat still. Why? Because it's very hard to identify the leak. Cause of the, most of the time is idiopathic. People just came one day and started to leak. Primarily, we know why, because we block the lymphatic system. Blood malignancies block the lymphatic system. Lymphatic malformation, the same. And this is the most difficult one, the last one, complication of cancer therapy. There's two of them. One, they can clog the thoracic duct with clot, and we see few patients. But more importantly is the immunotherapy obliterates mesenteric lymphatics. And there's a few papers came out recently that's observation papers. Now, we see this callus ascites post Gertruda, right? But we know, because we do lymphangiography, that it's literally obliteration of lymphatics. No contrast propagate from lymph nodes more distally. And there's not that much we can do. We'll try TPA, but I mean, not there yet. So again, this is a schematic thing. So causes is obstruction of the thoracic duct, the same retroperitoneal masses because of obstruction, but this obstruction happened at birth, and mesenteric lymphatic obstruction could be just mesenteric lymphangiography, volvulus, or cancer immunotherapy. I just said that. So this is a patient that get port, and you can see thing is hanging here. This is his clot. So the moment to clean it up, we did bypass surgery and remove a port. The callus ascites went away. This is lymphatic masses that leaking, so it's another treatment. It's diagnosis, so we can see the leak here. I don't know, it's not working. You have to trust me. All right, and what's intervention? Of course, obstruction of the thoracic duct, decompression, balloon, TPA, surgery. If you have retroperitoneal lymphatic masses, you can embolize them. It works, but it's stupid, right? You just go and infiltrate these masses because if it's big masses, what I do usually, I use combination of blood as a blood patch, glue, and sometimes sclerotherapy. You just infiltrate these masses and so, but it's stupid in the sense like you just throw in and hoping it will going to work. It's not very smart. But we do it and it works for majority of the patient if we have these huge, enormous masses, for sure. Mesenteric lymphangiectasia, some people have obstruction, a local obstruction of the lymphatic vessels in the bowel, and they're just sleeping. Volvulus, we have only 2 cases of chronic volvulus that cause obstruction of the mesenteric lymphatics and leakage. And cancer immunotherapy, I already talked to you, Denver shunt right now. This is pretty much the only thing we can do. This is a treatment. You see the previous case. We did this balloon here. And we'll talk about decompression tomorrow, all these techniques. And you can see flow is faster, so the patient is better. So this is intraoperatively. We actually can feed the patient with a cream with sodium black. And this sodium black makes all lymph vessels blue, so you can easily see them and you can operate on them. This is congenital mesenteric lymphatic obstruction. That's normal lymphatic bowel. This is abnormal. And that's what you see. You see these dilated lymphatics and nothing goes to the thoracic duct. Resection of the bowel cure the problem. Mesenteric lymphangiography, for sure. You can see definitely obstructed. You see how horrible, nothing goes to the thoracic duct. And slowly, we'll see in a second, you will see the leak. It's not very clear, but you see how important actually. Oh, here it comes. This is a leak. Why this patient has his pancreatitis, and that's how they develop this leak. So here, what we use, Lapidol. This is a two situation where Lapidol works, three situations actually, works amazingly well. Because people say, oh, yeah, did lymphangiography and calotox goes away. Don't trust that. Trust only three situations. Neonates with congenital isolated calothorax. You do lymphangiography, it goes away. Obstruction of the thoracic duct and calocitis, of course. Mesenteric lymphangiography, you inject Lapidol, it blocks these tiny leakages. And number 3, liver lymphangiography with Lapidol. Somebody will publish paper, and we also do, we don't need glue, we just inject Lapidol, it works quite well. So in this specific situation of mesenteric lymphangiography, again, I will say this word, I hate it, we're about to publish the paper, it's already finalized, it's accepted in SVR about ascites post-liver transplant. And there's a persistent ascites, there's 3 causes of that. And I didn't put this data yet, maybe we'll get tomorrow. Number 1, obstruction of the thoracic duct. In that case, will be Kyle's ascites. And you access mesenteric lymph nodes, you inject Lapidol, it goes to periphery, blocks this lymphatics, and it's getting better. Or you can open thoracic duct, but sometimes it's just obstructed here. And that's number 1. Number 2, liver lymphoria. And number 3 will be some portal vein stenosis. So during surgery, you can do mesenteric lymphangiography and inject glue directly into leakage point. So this is our old 2002 presentation, 42 patients. By now, we have almost 80. The numbers not as good as here. Actually, they drop. If we see thoracic duct visualized, it's probably 80%, and here is like more 65%. So we still have a group of people that we cannot treat well with callous ascites. Hopefully, developing all this new imaging will help us out. Thank you very much. Tomorrow will be another day, and I will talk about decompression of the thoracic duct, but I strongly feel that you guys will be doing, all of you, pretty soon, and we're happy to. Yeah.
Can you check for liver lymphatics? Inadvertently into the releasing ducts.
Yes, that's the reason we do those. I'm not cardiologist, right? Let me just answer. So you just do whatever you know how to biliary ducts look like, and you know how to portal vein. That's it. Just figure out. You can get bile ducts occasionally, rarely, but I know that there's a lot of issues with that with other people that are doing that, and they just embolize bile ducts. Whatever.
Sorry, thank you. I just wanted to ask if you had any experience with putting STS into the lymphatic system.
No.
I know some people.
I wouldn't. What kind of? I mean, for masses maybe, like with huge lymphatic masses. I did a few times, but I don't know. So what my technique for these masses is, you first flush everything with D5, clean up, right? Inject glue and push this glue with D5 to the periphery, right? While you already have your micropuncture in the groin, access to blood. You flush this with D5 to the periphery because you don't care embolizing masses. You want to embolize whole coming out of masses, right? And then you infiltrate with blood, and it works very well. So this is like sandwich kind of. D5, clean up the area, glue, push the glue and that works very well. I mean, again, I hate Satrodeckel because it's, again, like it's a crapshoot. You know, there's like sometimes it works, sometimes it doesn't work. With glue, you have, I feel, much higher chances. This is the only situation. Otherwise, why would you do it? Have glue work so well? So, you know, if you need to block something.
Thank you.
No, retroperitoneal lymphatics. I mean, you have everything. Sometimes we totally are isolated. Sometimes, yeah, and sometimes you actually don't see thoracic duct while doing intranodal lymphangiography, but you do liver and suddenly you see thoracic duct or mesenteric. So sometimes we disconnect, but it doesn't necessarily that people develop lymphedema. I mean, it's just compensated well. I mean, never been in a situation, but let's think. So one of the things when you try to, as I mentioned it a little bit, if you try to avoid reflux in the thoracic duct, put a cut inside the thoracic duct and inject D5 under pressure. And it wouldn't, and your glue would never, unless you just inject very, very strong, it wouldn't get it. So sometimes you have like, if you want to go selectively and you just inject, you put the cutter like 3-4 millimeters into the branch and it'll literally hanging by the hair. And he was like, oh, I'm going to reflux in the thoracic duct. It works amazing ways. Like one of us, usually it's Debbie and me, so Debbie will inject glue and then just pushing the D5. We have like 10 syringes and preventing, and it works. Mm-hmm. So we have 5 patients like that. So, but it's not chylosositis. It's actually liver lymphoria. Yeah, liver lymphoria. We submitted, again, I hate to do submitted. How many times I said it? During the last 1.5 years, suddenly I become much more like pushing my people to submit more papers. 5 cases we do, yeah. So definitely. The albumin, the SAG, small. So when you have a, yeah. So first thing when we have a site, it's not chylous. We will check the albumin, and if albumin is the SAG less than 1, albumin is very high, there's a high chance it's coming from a liver lymphangiography in that case. You know, it's actually Lapidol. We started to use Lapidol, and we accidentally discovered that. Because we did a guy that can, with idiopathic heart failure, with horrible ascites, 5, 6, 7 liters a week, but ejection fraction like not bad, like I don't know, 40, 50, I mean, but normal, almost normal. And I said, okay, let's do liver lymphangiography, like with no hope that I will see ever something. I do liver lymphangiography, I clear the CV leak, and I said, hold on, but with water-soluble contrast. It's like, okay, let's inject Lapidol. And we brought him to CT, actually. Let's inject Lapidol just to see better. It's like, oh, yeah, we'll see better. Oh, yeah, let's bring him next week, 2 weeks from now for embolization. And next 2 weeks from now, it's like, did he have parasitis? No, great. I don't understand what's going on. And then paper from GVIR came out that we treat post-surgical liver lymphoria with Lapidol, and it's worked. So I kind of, we have since I have 2 cases. Mm-hmm. I mean, so we don't embolize liver lymphatic. We only embolize liver lymphatic for liver lymphoria. We never do it for like PLE, for example. For PLE, we use liver lymphatics to show where's the leakage in total, because our technique is to inject retrograde, right? So I never embolize, besides liver lymphoria or communication between liver through a falciform ligament into the lungs. This is 2 situations where I actually need to do glue. And liver lymphoria, yeah, so it's transition. Meanwhile, I have like 2, 3 cases just Lapidol worked. I don't know, why should we do inject glue? Right. No, Lapidol by itself goes away. But Cooper cells eat it, you know. Oh, it stayed. You said it. So you mean I'm old school. So remember we used to have a CT portogram with Lapidol, we inject Lapidol into the hepatic artery to diagnose HCC, because HCC doesn't Cooper cells that eats they eat Lapidol, right? And everybody. So if 2 weeks later you get CT and there's areas that still Lapidol there, we know it's cancer. Maybe that's the situation. Like Cooper cells didn't find their way to this to eat. And glue stays for sure. Glue stays for a long time, but Lapidol goes away, eaten up by reticular cells, like Cooper says one is reticular something cells.
Thank you for the wonderful talk. 2 questions. Number one, in literature, I've read somewhere between, as you said, Lapidol, don't trust Lapidol to seal the thoracic duct leak, and literature says somewhere around 50–60%, sometimes 70%. What is your experience? And the second question, I've got one patient who keeps coming back with spontaneous, non-traumatic chylus ascites, idiopathic. Nothing more I can offer, but how do you approach those cases? Is there anything out of use that you?
So number one, so first we throw all imaging. Number one, if patient has thoracic duct, clean up thoracic duct. Right now we do it with TPA, right? It's much better than balloon, much better than if it works, right? We're still learning TPA within a year, only a year from now, but always I start with TPA, because TPA doesn't cause any damage. The idea is these people develop this chylus ascites idiopathic because they obstruct the thoracic duct. That's number one. If it does not work, then you do bypass thoracic duct bypass again as the first thing. Then you have to get access to mesenteric lymph nodes. So there's a 2 situation. You can do, I mean, do this at the same time. You know, if you do percutaneous, there's a thin guy. Are you from India or? Australia. I don't know what's the average size of people. So is it a biscuit? This also this country? Okay, like yes. Yeah. So you can do percutaneously if you're like a thin person. It's difficult. You need to have, I mean, not need to have, but you absolutely, okay, I would put it back. The hooked needle, very important, because it's just stay there and you can inject and inject and inject. Or you just open. Just, I have a 94-year-old, if somebody follows us on Slack, we have a Slack group, discussion group. So the 94-year-old, back surgery, chylus leak from the back surgery. Horrible, like 3 liters a day. And I couldn't find any lymph nodes. He's a big guy. Farmer, like he's still working in farms, like driving his whatever tractor. We opened his abdomen actually, like to that, and I found lymph nodes, tiny, inject Lapidol, just Lapidol, because it was far away going to the back, and he's cured. So this is, so pretty much you have to, it's some type of obstruction, right? Thoracic duct or mesenteric obstruction. But sometimes mesenteric is like totally obstructed, like pancreatitis. That's usually what pancreatitis does. It's just, it's whole lymphatics. Done, right? And there's no way for them to go, and it's just leaking, because one of the options, you inject Lapidol, it stops this leak, and other collaterals compensate. And so, but do I have a struggle with this patient? Yeah, I have one very, very famous person right now. We're very gentle with her. She's horrible, chylus ascites. I already did TPA, didn't work a little bit for a week. She didn't gain any weight, then do balloon. Another 3 weeks, she was symptoms. Monday I'm coming, she was for thoracic duct bypass. And the next step, because I clearly think that she is obstructed, we still don't have a drink yet. So when we have drink, it will like change everything, hopefully. And then next step, open abdomen, because she's big, and I couldn't see any mesenteric lymph nodes. And access these lymph nodes and try to infiltrate, see what you find, and do that. It's a big problem still. We even don't understand where the chyle is generated. Like, it's supposed to be proximal, intestinal, but it's duodenum, or because you theoretically say, okay, let's just cut the like the one that generates chyle, right? Intestinal resection. With drink, this is my huge hope that will make it like closer to 100%. Mycaluria is different than Indian caluria. Mycaluria is obstruction of the thoracic duct, reflux into the kidney. There's the two techniques. Right now, during the last 7-8 cases, we nailed it down 100%. So we actually don't. I have probably more than that, maybe 15 cases. Last was we all successful. We published 2 papers about that. One retrograde, based on Carlos Guevara idea, and one antegrade. So just so the idea is you have retrograde. I mean, in that case, I'll bring tomorrow. I'll show a few cases. So you have retroperitoneal lymphatics, obstruction of a lymphatic duct. In our cases, it's just obstruction because people were born like that, or clots. In your case, it will be most of it will be filaria. And there's a reflux into the kidney. So the goal is put the needle into these lymphatics and infiltrate glue. And just gently, but sometimes I even don't see this communication. On MRI, I always see them, but on the lymphangiograph, not always. So I just know approximately and just poke until I find, oops, the one goes on the kidney, inject glue, done. No sclerotherapy, nothing, because a few weeks ago we did sclerotherapy. Patient had been done in our place like 3 times sclerotherapy. It didn't work. I'm not sure where they also injected, but so you have to find this communication between the retroperitoneal and kidney. And it's actually not complicated. I mean, whatever, from our experience. Again, we maybe didn't from totally different animal, because I never had filarious patient. Yeah. It's not chylosositis, it's just chylosisitis, because liver lymphatics and so what happened is probably is a congestion of the mesenterium, and mesenterium become a little bit leaky, and ascites become chylous. Why? 200, right? But never go, like, if you feed this patient with steaks or whatever, butter chicken, it's not going to go to like 1 gram or 500. It will be like 200. So it's kind of actually liver cirrhosis ascites and not really chylous ascites. So, and so the moment, and it's clear, the moment you have patient with liver cirrhosis and portal thrombosis or CMV or IMV thrombosis, you have to take care of that first. Don't do any lymphatic procedures, just making sure you put tips, whatever, do your evaluation, management, and stuff like that. No, I don't know, there's nobody behind us, right? There's nobody behind us, right? Another lecture?
So in cases of venous thrombosis, subclavian vein thrombosis, that we get the chylothorax or even chylosositis at times, do only the angioplasty or of the venous side, or do you also simultaneously have to embolize the TD or open up the TD?
No, you always try to open it first. Yeah, definitely. So we have multiple cases of SVC syndrome, cause chylothorax or chylosositis, right? Yeah, even somebody, I give a talk about the relationship with the veins, and definitely have pressurized vein, it can cause you chylous leak somewhere, for sure. So first try to open the venous system, 100%.
After opening of the venous system also, a lot of times we are not able to see the thoracic duct. It doesn't get opacified.
What do you mean?
In the post-procedure. Like if you, still there is persistent chylothorax even after opening the venous system, and we do the lymphangiography, MR lymphangiography. There is a lot of collaterals here and there, but the thoracic duct doesn't get opacified.
You don't see opacification of the thoracic duct because it's clogged. So again, right now it's TPA for me. Like immediately, the first thing I will do. I mean, I go through phases of something that I love. It's like, oh, this is final solution. The liver lymphangiography was like, oh yeah, that's it. The answer for everything. That mesenteric lymphangiography. Right now, TPA for me, the whole, and then of course, a few years from now, I will say probably it's not going to work. So we do adults like 2 milligram, dwell for 20 minutes, and another 2 milligram and pull out. I'm not sure if it's right. We actually get quite a lot of money from ARPA, where we will do clinical trial, and we do also always analysis of the clots. So if you take clot and I do a lot of harvesting lymph from people, for whatever, 1,000 people at once. So if you don't put it into the ADTA tube, will clog within 3-4 hours. It will become gel, hard gel. So that's basis of plastic bronchitis, for example, why plastic bronchitis become plastic bronchitis. And that's what we're going to do. We actually will harvest from pigs and from humans' lymph, and we'll try to use different concentration and try to do smarter. We'll also do sophisticated analysis of a clot, understand what's inside. We know it's thrombin mediated. It's there's no platelets, of course, there. It's fibrinogen and thrombin. And we have one researcher that think he figured out on like mice, that I'm not sure. Everything that like someone talking about mice. So they, you know what? If you drop so mice doesn't translate to humans ever, right? Zebrafish or then rats may be bigger than pigs, and then like, you know. So because if you drop the squirrel from an airplane, it will land no problems. So translation from small animals to humans is very difficult. But he thinks he'd figure out, and he get a lot of money with us together because we're developing lymphatic stent, and he was developing anticoagulation lymphatic. And he's anticoagulation a thrombin inhibitor. So that's what he thinks that, and I think that's what we're going to do as well. So based on the, if we finish with study, we still didn't get us money. Next week they're going to tell us if they're going to deal with like small piece to whatever big grant. So if we do, so we'll have a lot of answers very soon, because it's we'll start working already in January. Harvest the clots and do STPAs and stuff like that. Thank you very much. Please come tomorrow. I'll talk a bit more about decompression, protein enteropathy, abdominal pain, lymphedema, and so on and so on. And calorie, I guess.
Water. துணி நான் மூடி வச்சுட்டு வந்துடலாம்.
4 மணி நேரம் க்ளோஸ்டா வாட்ரு. 4 மணி நேரம் க்ளோஸ்.
4 தானா? அதான் 3:30 இதுவா?
டே போட்டுக்க. டே 1 அதுதான். டே 1 தான். டே 1. அப்புறம் அதான் 4 மணி ஆயிடுச்சு.
இது ரெண்டும் இதுனா இது ப்ரொமோஷனு 2 பேரும் அவங்களுக்கு இதுதான்.
அப்போ அவ்வளோதான். காலையில் 4 பேசணும். அவ்வளோ காலையில் பேசினேன். 2 மணிக்கு 3 மணிக்கு எதையும் காலையிலேருந்து பேசணும் எல்லாம்.
அப்போ நாளைக்கு பார்த்து வச்சுக்கலாம்.
நம்ம அவ்வளோ எல்லாரும் நடக்குது இல்லை மொத்த ஆள் நம்ம எது வாட்டர் மட்டும் போதும்.
இண்டிது
நம்மளுக்கு வாட்டர் மட்டும் போதும்.
பார்த்து சீராக என்ன பண்ணுறது ஆள் ஓசி இது நம்மகிட்ட கிட்ட இல்லை.
இது நம்மகிட்ட எங்கே இருக்குது?
ஹைலா வாட்ரு
டே 2.
இது 9 இருக்குதா?
நாளைக்கு தான் 9. டே 2 இந்த எப்படி 9
11:30 12:30
அதுதான் நம்மளுக்கு. அதுதான் நம்மளுக்கு. சரி அதுக்கப்புறம் நம்மளுக்கு ஃபங்க்ஷன் போயிடுது.
இது வந்து வேற
ஆள் இருப்பேன். ஆப்போசிட் ஆளு அந்த ஆளு எல்லாம்
டே 3 கிளாஸ் தான். அப்போ நாளைக்கு மதியானம் தானா?
நாளைக்கு மதியம் வரைக்கும்ண்ணா.
நிறையா பேர் 10 மணி இருக்கேன். 3ஆம் நாள் வருஷம் எவ்வளோ ஆகும்? வீடு வாட்டரே இல்லை.
அடுத்த வாட்டில் ஒரு 1
ரேட்டு 12 மணி வரைக்கும். அத்தனை 12 மணி வரைக்கும் தானா? ஆனால் இது
2 கூடாது.
அதான் இது 9லேருந்து 11:30 9லேருந்து 12 வரைக்கும். 9 வரைக்கும்
4ஆம் நாள் பார்த்துருவேன்.
நம்மளுக்கு இல்லவே இல்லை. விண்டோ இது இந்த ஒரு 9:30 நாளைக்கு தான் கதை. நாளைக்கு தான் கதை.
இதே 1
இது தேவனா பேப்பரில் நம்ம பேர் இல்லை. நான் ஆயில் ஆஃப் ரெண்டு தான் இருக்கு. அவங்களுக்கும் 9:30 1 மணி நேரம் தான் போடுறாங்க.
அதான் அதெல்லாம் 3 நாள் மட்டும் சொல்லிடுறாங்க. இந்த ஃபங்க்ஷன் நம்ம நாள் இருக்கிறத சொல்லல.
என் திங்கி இது ஃபுல்லாக பார்ட்டி மாதிரி இருக்கும்னு நினைக்கிறேன். நம்மளாம் அனுப்பிச்சிடுவோம். நினைக்கிறேன்
3 நாள் தான் கணக்கு. வச்சுக்க இதுக்கப்புறம் கொஞ்சம் கட்டி பார்த்தேன்.
எதனா வைக்கிறது இங்கே வச்சு சொல்கிறீங்களா? நான் எடுத்துட்டு வாங்க.
போமா
துணி மட்டும் இருந்துச்சுன்னா அப்படியே மூடிட்டு போயிடலாம்.
அங்கே முடிஞ்சிச்சாமா?
அவருக்கு 5:30 6:30 சொன்னார்.
இங்கே முடிஞ்சிச்சாமா? இங்கே எப்படி தானே கேட்டா சொன்னாங்க.
இங்கே நம்ம 4 மணி வரைக்கும் தான் உங்களுக்கு 4 மணி வரைக்கும் தான் ப்ரோக்ராமே அப்படின்னாரு.
இப்போ முடிஞ்சிச்சு அவ்வளோதானா?
அங்கே எடுத்துன்னு வந்து பேசுறீங்களா? இங்கே எடுத்துட்டு போயிடலாம்.
எங்கே அங்கே போயிடலாம். அங்கே என்ன இங்கே பண்ணிட்டு போயிடலாம். லாக் அடியில் தூக்கி போடுங்க. லாக் மட்டும் அடியில் தூக்கி போட்டு இல்லையா? சரியா? துண்டு போட்டு மூடுறியா? வண்டி சார் இருக்குது
அருணா தான் வச்சிருப்பாரு.
di sini ya, bangun lah. Except ये तो होता है वन सेट बार के लिए और ऐसे वहाँ भी कैसे ना और इसमें बोलो ये क्या है अंदर रोज वहाँ पे बैठती हूँ वहाँ पे बैठती हूँ अंदर देखेंगे क्यों नहीं है
ஆஃப் பண்ணிட்டேன் பவர் ஆஃப் போது ஃபுல்லாக ஆஃப் பண்ணுன்னா அந்த மைக் ஆஃப் ஆகும் மைக் எல்லாமே அந்த இதுக்குள்ள வச்சிருக்கேன் பாக்ஸ்க்குள்ளே
மற்றவங்க ஜென்செட் ஆஃப் பண்ண சொல்லிடுறாங்க 6 மணிக்கு சொல்லு புரியுதா அவங்க எல்லா லெவலுக்கு பைசா வளர்த்துட்டு அதுக்கு இல்லை திடீர்னு வந்து நிற்பானுங்க ஏதோ நமக்கு கையில் ஆஃப் பண்ணிடுவோம் இது லேப்டாப் இது ஆஃப் பண்ணாத பெரிய தான் பேக்கிங் அதெல்லாம் ஆஃப் தான் டிப்பர் லாக் பண்ணட்டா இரு பேச இந்த லேப்டாப் காலையில் யூபிஎஸ் ஒரு வேலை காட்டுச்சு நான் போக்க தானே நினைச்சு மறுபடியும் ஆஃப் பண்ணி ஆன் பண்ண ஆஃப் பண்ணி அப்படி இருக்கட்டா அதான் நான் எடுக்கணும் ஒரு சிங்கிள் பாக்ஸ் தனியாக ஆஃப் பண்ணிங்க ஆஃப் பண்ணிடுச்சு ஆஃப் பண்ணிடுச்சு பவர் ஆஃப் பண்ணல ரிப்பேர் பண்ணல ஆஃப் பண்ணிடுச்சு திடீர்னு வந்தால் நாளைக்கு ஆன் பண்ணுறாங்க அவனோட கருத்து பற்றி தெரியாது என்ன ஓடிட்டு இருக்கு அது அது எங்கிட்டு போடுங்க நம்ம என்ன பண்ணி
சரத்காக சைன் பண்ணணும்னு சொல்லியிருந்தாங்க.
யாரு
சைன் பண்ணணும்னு சொல்லியிருந்தாங்க?
யார்
இங்க காலையில பிரசன்டேஷனுக்கு இல்லையா?
இல்லை எல்லாம் போயிட்டாங்களா சார்?
சரி தேங்க்ஸ்.
So the hall is empty and no one is here. Okay. Okay.
கிளம்புப்பா. ஓகே ஓகே அங்கே வரும்போது அங்கே பார்க்கணும். ஓகே
வாங்களா
எடுத்து வைக்க வேண்டாமா? இதில் விரிச்சு வச்சுட்டு வந்தா வேணுமா? ஆ